even before it was formed. He is one of the instrumental anesthesiologists in really advocating and advancing ultrasound guided regional anesthesia in this country as such, and taking it over far across in the continents. He is the director of the Axon Anesthesia Company in Hyderabad, which almost covers maybe 3/4 of Hyderabad's anesthesia. He runs a fellowship on behalf of Academy of Regional Anesthesia. His workshops are really most sought after. So I really welcome you and heartfelt thanks for being here today with us. Over to you, Dr. Gopal.
Thank you, Roshali, for your very ceremonial introduction. Can you see and hear me, all of you?
Yes, sir.
Yeah, thank you, Ritesh. To begin with, a belated Happy New Year to all the organizers, fellow faculty members, and all the delegates that have logged in for this webinar. And thanks to Ritesh also for taking up this very important assignment with an almost missionary zeal and doing such a good job of conducting this particular series of meetings. Over the next 10 minutes, I'll be speaking to you on how I do an ultrasound-guided lumbar plexus block. First and foremost, the disclaimer. I am not an expert with ultrasound guidance for lumbar plexus blocks. I do quite a few lumbar plexus blocks, almost 8 or 10 every month in combination with sacral plexus blocks, but I tend to prefer peripheral nerve stimulation, and it's not very often that I use ultrasound. But since the topic has been allotted to me, I'll do my best to justify Ritesh's faith in me. This is a picture of the Mariana Trench, which is just east of the Philippines in the Pacific Ocean. This is said to be the deepest place on planet Earth, wherein the depth plunges to as much as 11,000 meters below the sea level. And this exceeds the entire height of the Mount Everest. It is interesting to note that beyond a depth of 1,000 meters, there is complete darkness, which means that light does not penetrate beyond 1,000 meters into the sea. If you transfer this analogy to ultrasound, the deeper you go, more the attenuation of the ultrasound waves, and deeper structures are quite difficult to pick up with ultrasound, which is why when you wish to visualize deeper structures, you need a low frequency transducer, which affords greater penetration. And the trade-off is that the quality of the image is not as good. So this is the problem that plagues ultrasound guidance for a lumbar plexus block. A brief review of the technical approaches to the lumbar plexus. Winnie and colleagues in 1973 spoke about the now defunct 3-in-1 block via an anterior approach. The very next year, in 74, Winnie and the same colleagues came up with the posterior approach to the lumbar plexus, which was guided entirely by landmark technique and tactile feedback. Cheyenne and colleagues in 1976 introduced the concept of loss of resistance, and they called this the psoas compartment block. We today know that there is no such compartment that exists. Parkinson and colleagues in 1989 were the first to use peripheral nerve stimulation for identifying the lumbar plexus. And it was Kirschmeyer and Bernard Morrigal and colleagues in 2001 who were the first to use ultrasound guidance for lumbar plexus. And today, the current gold standard that is advocated by textbooks and leading journals is that we use a combination of both ultrasound guidance and peripheral nerve stimulation. This is the one block which has a very high potential for bleeding. And that is why this is considered to be an advanced level block, and it is not meant to be performed by beginners in the absence of adequate supervision by trained seniors. As I said a while ago, it was Kirschmeyer and colleagues who, in a publication in the Anaesthesia and Analgesia journal in 2001, who spoke about ultrasound guidance for a posterior approach to the lumbar plexus. And in this picture, we see the lumbar vertebrae, and this is the parasagittal placement of the probe. And this is the sort of images that they saw. In those days, the ultrasound technology was not as evolved as it is today. And here, this is the transverse placement of the probe. And though I could identify all the muscles, the erector spinae, the quadratus lumborum, and the psoas major muscle, identification of the lumbar root or the lumbar paravertebral space or the lumbar plexus in itself was not possible at that point of time. So talking about ultrasound, I did say that we use low frequency curve transducer. This is a probe which fires between 2 and 5 megahertz, and it has a footprint of 60 millimeters and 60 centimeters, sorry. This is sagittal placement of the probe, which is just paramedian, and this is a transverse placement of the probe. So there are two ways of viewing the lumbar plexus with ultrasound. One is a long axis and the other would be short axis. And we look at first the paramedian sagittal transverse process view. So this would be the sacrum, that would be L5, and that would be L4. We typically choose the space between L4 and L5 when we perform a lumbar plexus block with ultrasound guidance. And this is how the probe is placed in the parasagittal plane overlying the transverse processes. So you will not only see the transverse process, but there is a window in between two contiguous transverse processes. So that would be the erector spinae, which is most posterior. That would be the transverse process, another transverse process, and this would be the other transverse process. This is what Manoj Karmakar has called the ultrasound trident. And this in between the two transverse processes would be the psoas major muscle. And at the junction of the anterior 2/3 and the posterior 1/3, that would be the lumbar plexus nerves that would emanate from the lumbar paravertebral space. So this is a small video. This is the peritoneum there, and the lumbar plexus would lie in that particular area. And before we use ultrasound, it is quite important to mark the surface anatomical landmarks, which makes it easier for us to place the transducer on the patient's skin. And this is how the transducer is placed. It is paramedian and it is in long axis. And the needle in this particular picture is going from chordae towards the capillate direction, but it can also go out of plane with the ultrasound beam. This particular approach is not very popular, and the more popular approach would be the other scan, which involves transverse placement of the probe. So while talking of the paramedian transverse oblique scan. We say oblique because the probe is preferentially tilted towards the midline. So you can start by placing the probe either just lateral to the transverse process here, or we can place the probe in the flank. And when we place the probe in the flank, we identify the muscles which are likened to a shamrock by Hens Borglum and colleagues, which they came up with in 2013. So this is how you would place the probe with the patient in lateral position when it is just lateral to the transverse process. And the needle would go in close proximity to the probe. So aligning the needle with the ultrasound beam with this sort of placement of the probe is quite easy. So this is what you would see with the transverse process view. You would see the transverse process here. That would be the erector spinae. This would be the quadratus lumborum, and this would be the psoas muscle there. And this here, emerging here, would be the nerve of the lumbar plexus in that particular corresponding vertebra. And having identified the transverse process, if we gently slide the probe, either cephalad or caudad, the transverse process is now replaced by the smaller articular process. So technically, when the needle is introduced and it makes its way towards this particular lumbar plexus here, we don't have to hit the transverse process and walk off it. So that is the technical advantage of using the articular process view. And this is a picture which was put in a journal by Manoj Karmakar. This is a proper ergonomic placement of the operator with regard to the machine. And as you can see here, dual guidance is being used. A peripheral nerve stimulator is also attached, and the needle is going in close proximity to the probe that is being placed just lateral to the transverse process in line with the ultrasound beam. And the other way of doing it is to place the probe in the flank. But when we place the probe in the flank, as you can see here, the needle is at a certain distance from the probe, which makes it a little more difficult to orient this needle within that 1 millimeter thickness of the ultrasound beam. So what we tend to identify is the shamrock. This is the holy flower of the Republic of Ireland. As you can see here, it has 3 flowers and it has got a stem. So when we look here, the stem is the transverse process of the corresponding vertebra. One flower would be the hypoechoic quadratus lumborum muscle. This would be the erector spinae, which is the other flower, and this would be the psoas major muscle. And that here would be the nerve of the lumbar plexus exiting the intervertebral foramen. So this is the transverse process view. And as I said, if we move the probe gently, either caudad or cephalad, the transverse process is gone, and that is replaced by the articular process. And this would be the lumbar plexus there, the nerve of the lumbar plexus. So if the needle is coming in from here, there would be a direct access towards the lumbar plexus. This here would be the great vessel. If the patient is on the right side, that would be the IVC, and on the left side, it would be the aorta. So this is how you would see it. If the probe is placed just lateral to the transverse process, the muscle which immediately grabs your attention would be the erector spinae. But when the probe is placed in the flank, at the apex would lie the quadratus lumborum. So that is the difference in imaging that we need to keep in mind. I'll end with a simple video. In this, you really can't pick up the needle. This was one of the few blocks I performed with ultrasound a couple of years ago. But you can identify the transverse process here. You can identify the body of the vertebra. And this is the psoas muscle over here. and on top would be the quadratus lumborum. And you can see the local anesthetic going into the psoas muscle in the vicinity of the lumbar plexus there. And you can see the nerve beginning to stand out against the hypoechoic background of the local anesthetic as more and more local anesthetic is injected there. So that's about it, Ritesh. I suppose I've taken a little more than 10 minutes. Thank you very much for your time and attention.
Thank you, sir. Somita, madam, you take over for the rest of the sessions. Somita, madam, the next talk will be by Dr. Surajit. The PNS guided lumbar plexus will be followed later on. Sir had some problem with his laptop. So next talk will be by Surajit. Somita, madam, you just take over.
Sure. Good evening, everyone. Yeah, it's a pleasure to moderate this session. Wishing everyone a happy 2021. The next session is going to be on femoral nerve and lateral femoral cutaneous nerve blocks. We have two speakers for this session, Dr. Surajit Giri, who will be speaking on the PNS guided technique, and Dr. Harshal, who will be speaking on the ultrasound guided technique. So as all of us know that Dr. Surajit Giri is not a new face. He's been a speaker in all the AORA conferences, as well as he's been a founder member of Academy of Regional Anesthesia, founder, executive member. He's also a governing council member. He's a current secretary of IMA. But what is new about him that I got to know recently, that he's an ardent snake bite social activist. That is, they've been guiding people about the superstitions regarding the snakes and also trying to treat the patients who comes with snake bite. So without any further delay, I would request Dr. Surajit Giri to start with his talk.
Yeah, thank you, Somita ma'am. And hope I'm audible and visible. The slides are visible?
Yes,
okay.
Your slides are available. Carry on. Yeah.
Thank you. Good evening, ladies and gentlemen. And I have been assigned for femoral and lateral femoral kidneys nerve block and landmark and the PNS guided. And I declare that I taken the written consent from the patient and the parents for photography and videography. And what I'm going to show in the subsequent slides are my own experiences. And thanks to Dr. Sandeep Diwan sir for giving his consent to publish few of the cadaveric dissection photo from his book, Regional Nerve Blocks. Now, femoral nerve can be blocked above inguinal ligament and below inguinal ligament. This is the inguinal ligament. So you can block the femoral nerve below inguinal ligament at the inguinal crease level and above inguinal ligament at this level. Now, if you go below inguinal level, at the inguinal crease level, the femoral nerve is very close to the femoral artery. See, this is the femoral artery, this is the femoral nerve. So in the inguinal crease level, we insert the needle somewhere 0.5 centimeter lateral to the femoral artery. But if you go above the inguinal ligament, that is called the suprainguinal area, here the femoral nerve is far lateral from the femoral artery. So we insert the needle here, that is around 2.5 to 3 centimeter lateral to the femoral arterial pulsation. Now, whether it is above ligament or below ligament, the arrangements are always same. That is the vein, artery, nerve. Vein, artery, nerve. So it is mnemonics is VAN, V-A-N. Now the lateral femoral kidneys nerve is again, this is a far lateral to the femoral artery. You can see this is the lateral femoral kidneys nerve. And if you want to block this nerve, you have to palpate and locate the anterior superior iliac spine. This is the anterior superior iliac spine. You have to go 3 centimeter medial and 3 centimeter caudal. This is the needle insertion point. Now this kid, she came for fracture shaft femur, and we are going to demonstrate about the lateral femoral kidneys nerve block. So you can take any blunt needle, but here I am showing with an stimuloplex needle, and the landmarks are anterior superior iliac spine going 3 centimeter medial, 3 centimeter caudal, and you have to look for the fast pop. Means only you will get a one pop from the fascia lata and then deposit the local anesthetics. So you can puncture needle, you get the pop. See, you got a distinct pop, and you can see the distinct pop from the distance also. So that how you have to you can block the lateral femoral kidneys nerve block. Now you have to remember the osteotomy, dermatom, and the myotom. The femoral nerve, suppose this area, surgery is here, anterior part of the thigh. Yes, you can give the femoral nerve block. For knee surgery, yes, femoral nerve block is definitely a choice. For patellar surgery or arthroscopic surgery, or fracture shaft femur, fracture supracandalar femur, fracture neck femur, trochanteric femur, the femoral nerve block is an excellent anesthetic and analgesic technique, ladies and gentlemen. Now, at the inguinal level, femoral nerve has a lot of divisions. This is the anterior division and this is the posterior division. Anterior division is supplying the sartorius muscle. Okay, and here this is the posterior division which are supplying the quadriceps muscle. Now, in the inguinal level, when you insert the needle, in 90% of the patient, you are going to get these twitches. Means you are going to stimulate this nerve. Your needle will be somewhere here, and you will going to get the sartorial twitches. The sartorial contraction will be there. That is not our ideal response, ladies and gentlemen. So you have to redirect the needle slightly lateral and deep, so that we have to stimulate this posterior division, and we should get the quadriceps contraction and patellar dance. Now, this is the ideal repetitive response. You see, I'm getting the quadriceps twitches as well as the patellar dances. This should be the end motor response. So you deposit 0.5 ml of 0.5% of levobuprofen, 20 ml of local anesthetics, only 20 ml of local anesthetic is sufficient, and the patellar surgery is going on very nicely. So another indication is as an honorable block, what we are using in our institute. Now, elderly patient with a hip fracture, when it comes to the hospital, they have a lot of comorbidities, and this pain will aggravate their comorbid conditions, and the patient become critically ill. So it is our duty to control his pain. So this femoral nerve is one of the example we can control the pain. But remember, if the patient is having a trochanteric fracture, when there is a trochanteric fracture, there is a lot of swelling, and it will distorts the anatomy of the inguinal region. So in trochanteric fracture, we insert the needle around 2 centimeter lateral to the femoral artery. This is the crease, you see, inguinal crease. As we have shown in the previous slide, that we are going to insert a needle at inguinal crease level 0.5 centimeter lateral to the femoral artery, is not it? But here, as the patient has a trochanter fracture and there is a lot of swelling, we are going in 2 centimeter lateral to the femoral arterial pulsation. So even if I am going 2 centimeter lateral to the femoral arterial pulsation, I am getting only the anterior divisional twitches, ladies and gentlemen. Here I am going to get the sartorial twitches. See, this is the sartorial twitches. This is the anterior division twitches. So if you deposit local anesthetic here, block will not going to work. So what we'll do, I'm directing the needle slightly laterally and the deep, and so that I could get the patellar dances. This is the patellar dances I'm getting. So this only for the trochanter fracture, ladies and gentlemen, at the inguinal level, you insert the needle 2 centimeters lateral to the femoral arterial pulsation. Then we have inserted the femoral catheter, that is non-stimulating catheter, at the casualty itself, you can see, and then this tunneling, and then patient was posted for surgery after 6 hours. And we are giving only bupivacaine 5 milligram plus fentanyl 20 milligram in the as an spinal anesthetics. So this femoral block, decreasing the pain. Then we did the investigation. Then we shifted the patient for the operation, and then we are reducing the local anesthetics in the spinal level, because the patient is having the DCMP with an ejection fraction of around 12%, ladies and gentlemen. So this is another indication which we are using very regularly, that is for a TBW patella. So this is at the inguinal crease level. This is the femoral artery. As there is no anatomical distortion is there, so we will go 0.5% lateral to the femoral arterial pulsation. So this is the femoral artery. We are going just 0.5 centimeter lateral to the femoral artery, and we are taking the 50 mm stimuloplex needle, and our end motor response is the patellar twitches, the quadriceps contraction, and after that we have deposited 20 ml of 0.5% bupivacaine. And see here what the surgeon is doing. One patient out of 10, they will complain pain during surgery under femoral block for the TBW surgery, when the surgeon dissects in this area, and this area is maybe supplied by the fibular nerve, maybe supplied by the obturator nerve. For that, you do not need any extra block, ladies and gentlemen. You hand over 10 ml of 1.5% lignocaine adrenaline to the surgeon, and he will infiltrate like this in this area, including the prepatellar fossa, and the anesthesia and analgesia is complete. So resistant femoral block plus infiltration by the surgeon is most of the time is sufficient for TBW surgery. Now this is another indication which we are doing it regularly, and this is a kid, a 3-year boy. He came for fracture shaft femur, and we went for the that is femoral block and followed by spinal anesthetics. If the patient is posted for hip spica, we give femoral block followed by sedation. But if the patient is posted for plating, then you go for the femoral block followed by spinal anesthetics. Now, if you give only spinal anesthesia for the neonates or children or kid, then it is an effect of around 60 to you can say around 30 to 45 minutes, and that may not be sufficient. By giving this femoral block, we are extending the spinal anesthetics and durations. Not the spinal anesthetics, we are extending the analgesic duration, and then ultimately the patient is pain-free during operation and also after the operation. Now, what we have described till now is the infrainguinal approach. So that is the what we are going to describe about the suprainguinal approach for the femoral nerve block. So this is the again supine position, trochanteric flexor, and this is, you can see, this is the inguinal crease, and this is the inguinal ligament. This is the anterosuperior spine, and this is the pubic tubercle. This is the inguinal ligament. We are going 2 centimeters above the inguinal ligament, and this was around femoral artery, and we palpate the femoral artery. We went 2.5 to 3 centimeter lateral to the femoral arterial pulsation, and we punctured the skin. Then we found a pop from the fascia lata, and again we will bounce and followed by pop from the fascia iliaca. And then we got the patellar twitches, and this is our end motor response, and we reoriented the needle so that we could get the twitches at around 0.4, and then deposited local anesthetics. And this is again in the preoperative room for analgesia purposes, and later on it was extended for this intraoperative as well as the postoperative pain management. Now, after giving the suprainguinal block, we have assessed the block, and this is the cold lipidem in my hand. So I put over the anterior part of the thigh and asked the patient whether he is getting a cold sensation. He says, no, I'm not getting any cold sensation, means femoral nerve is blocked completely. And then lateral part of the thigh, and again he says he's not getting any cold sensation, means lateral femoral cutaneous nerve is also blocked completely. And in the upper medial part of the thigh for the obturator nerve, and patient says, yes, I'm getting little bit of cold sensation, means some part of the obturator nerve is also blocked. So within single injection at suprainguinal level, ladies and gentlemen, we are blocking the femoral, we are blocking the lateral femoral cutaneous nerve, and little bit of obturator nerve. So we have compared 100 patients. There is a 50 for the supra and 50 for the infrainguinal approaches, and we found that the onset time for the suprainguinal approach is only 13 minutes versus 30 minutes for infrainguinal approach, and success rate is 99% for the suprainguinal versus 94% in infrainguinal, and vessel puncture you can see 11% for infrainguinal and versus 1% for suprainguinal approach. So suprainguinal has a definitive role, and if you want to block within single injection femoral nerve, lateral femoral cutaneous nerve, and little bit of obturator nerve, and if you want to increase the success rate, then suprainguinal approach may be an answer for you. Now, if you do not have an ultrasound, you do not have a PNS machine, so can you give the femoral nerve block? Answer is yes. That is called a fascia iliaca compartment block. So here we are using epidural needle, and landmarks are, this is the anterosuperior spine, this is the pubic tubercle, and draw a line between anterosuperior spine as well as the pubic tubercle, and take the lateral, this is the 1/3, this is the point, and this is lateral 1/3, and this is the medial 2/3, and that is the point, and you go 1 centimeter below that. Okay, and we are taking the epidural needle. I'm taking the LOR to normal saline. We'll go slowly, very slow and meticulously, so that I could get, yes, I'm getting the pop from the fascia lata. And again, I'm going very slowly. You should be very meticulous, otherwise you will not going to feel the pop. You'll go slow, and very slow and meticulously. I'm going to get the second pop. Yes, I got the second pop from fascia iliaca. And then again, it is in the preoperative area. We are inserting the catheters for analgesia. And this is another patient. Again, LOR2 saline. Yes, I got the first pop from, this is the first pop from fascia lata. And again, we are going, this is the second pop by the fascia iliaca, and inserting the catheter for hip flexor. And you can use the air also. This is the first pop. I'm using LOR2 air. So this is the first pop by the fascia lata, and this is another pop by the fascia iliaca. So you can insert a needle in the perpendicular direction also, or you can in the 45-degree angle. It doesn't matter. Only what we want, that we want to see the pop from the fascia lata and the fascia iliaca. Now you do not have any epidural needle. What will do? You can take a blunt needle, or in my case here I'm showing an stimuplex needle, and the landmark is same. And as the patient is very much obese, I'm stretching the skin and puncturing the skin. Yes, and then I come out and we look for the bounce. See, bounce about the fascia lata, followed by pop. Again, bounce about the fascia iliaca, followed by pop. So second pop. So even if you do not have any instruments, even if you have a PNS, even if you have no ultrasounds, you can just with a needle itself, blunt needle, you can give the fascia iliaca compartment block. Now, what is the difference between FNB, femoral nerve block, and fascia iliaca compartment block? In a femoral nerve, we are injecting here, that is nearby to the femoral nerve. But in the fascia iliaca, we are away from the femoral nerve. This is the femoral nerve. We are away from the femoral nerve. So it is a compartment block, facial compartment block. And here you deposit 35 to 40 ml of local anesthetic. It will slowly track and it will block the femoral nerve. So here you require more volume, that is 35 to 40 ml. But in the femoral nerve block, you require only 20 ml of local anesthetics. And in the infrainguinal approach, you are not blocking the lateral femoral kidney nerve, but here you will block the femoral and lateral femoral kidney nerve. But for the suprainguinal FNB, you are also blocking the lateral femoral kidney nerve. Before giving the incision, always assess the block, like 4 P's for the lower limb. This is for the sciatic. You know that is for the lower limb. You need to block the sciatic nerve also. So ask the patient to push. If he cannot push, means TBL is gone, and means sciatic is blocked. And ask the patient to pull inside. If he cannot do, means obturator nerve is blocked. Ask the patient to punt, means kick in the air. If he cannot do, means femoral nerve is blocked completely. And pinch about the lateral part of the thigh. If he cannot feel the pinch sensation, means also the lateral femoral kidney nerve is blocked completely. So that indicates the completeness of analgesia and anesthesia for surgery. And now patient is ready for incision and surgery, ladies and gentlemen. And this is what I am submitting to all of you. And thank you for patient hearing. Over to ma'am. Samita ma'am.
Thank you, Dr. Surajit, for your talk. Please stay on, because we're going to have the questions after this session. The next, we are going to move to Dr. Harshal Wagh. He is going to speak on ultrasound guidance for femoral nerve as well as for lateral femoral cutaneous nerve. Dr. Harshal Wagh is a young and a dynamic face of AORA. And he's also an executive member of Academy of Regional Anesthesia, and he works as a consultant anesthesiologist at Kokilaben Ambani Hospital in Mumbai, and also has several publications to his regard. And he is also heading the AORA Fellowship program at his hospital. So I would request Dr. Harshal to start with his talk.
Thank you very much, Dr. Somita. Can you see my slides?
Yeah, we can see your slide. We can hear you also.
Yeah, can I start? Yeah.
Yes.
So good evening, everyone. Very big thank you to the AORA family and for this opportunity. I'm going to be talking about ultrasound guided femoral nerve block and ultrasound guided lateral femoral cutaneous nerve block. Quick touch on the anatomy. I think all of us already know the anatomy, but I'm going to just touch on it. So you all know that the femoral nerve and the lateral femoral cutaneous nerve come from the lumbar plexus, and the lumbar plexus lies in the substance of the psoas major muscle, and they enter the abdomen from the lateral wall of the psoas major muscle. The femoral nerve and the lateral femoral cutaneous nerve enter the thigh below the inguinal ligament. The femoral nerve lies lateral to the femoral vessels, but it's important to remember that it is enclosed in a separate sheath. So that is important to remember when you're giving a ultrasound guided femoral nerve block, and explain to it coming later. Now, as Dr. Surajit also mentioned, it is important to be aware of the dermatomes, the myotomes, and the osteotomes that the nerve supplies, because in spite of having a good nerve block, sometimes because you're not aware of the dermatomes, myotomes, and osteotomes, the area that is area of interest may not be necessarily blocked. So it is important to know these as well. Now, since this is the way I do it session, I'm going to talk exactly the way I do it. So for an ultrasound guided femoral nerve block in an averagely built adult, I would use a linear probe, which is a high frequency probe. I also tend to use the nerve stimulator wherever possible. Nowadays, since with us is available, we also use the injection pressure restrictor. So the reason for using these is basically not only it gives me an added advantage in terms of documentation and medical legal, but I would also recommend students and those people who are starting to learn ultrasound guided to use or the dual, or nowadays the triple modality, to help in increasing the safety of the block. Now, as a holistic approach to doing the femoral nerve block, or any block for that matter, the way I do it is everybody gets a pre-op visit. I explain to them what the nerve block involves. I think it's a good idea to do a pre-procedure scout scan, because once you don up with all the septic precautions, you get your equipment ready, then you don't want any surprises when you do the scan. So pre-procedure scout scan always helps. It gives you an idea of what the area looks like, and you have a rough idea of the USG guided picture that is going to be there, your target that you're going to give. Now, a dynamic scan is another thing that I always do. By way of dynamic scan, I mean that I scan the area in all four directions, so that again there is no surprises, and I know what I'm dealing with when I get ready for the block. It is important to remember, or important to scan the target area, but more importantly, it is important to know what you want to avoid when your needle trajectory comes towards the nerve that you are targeting. Color Doppler is something again that I would highly recommend in doing all blocks, because then you don't want to go through any vascular structures on your through your needle trajectory. So there are a few things that you would always do. Now, picture speaks many words. I don't think I need to say too much on this. This is the way I would do a femoral nerve block, or for that matter, any nerve block. I would do with full aseptic precautions, whether it is a single shot block or a catheter technique. Ergonomics is something which I think all of us have been discussing so far. Is you have your the patient, you have the ultrasound machine, and you have the monitor on and the anesthesia machine in front of you, so you don't need to change your head direction when you're doing the block. Everything is in one view. For ultrasound guided femoral nerve block, I usually prefer, as I said, triple modality wherever I use. By triple modality, I mean the ultrasound, the nerve stimulator, as well as the injection pressure restrictor. For approaches wise, unless otherwise, for whatever reason I can't do, then I would prefer an in-plane approach to the femoral nerve, and an in-plane approach even to the lateral femoral cutaneous nerve. While injecting local anesthetic, something that I always follow and is also recommended is to inject in small aliquots, so that you are not only seeing the injection being done, but at the same time, in case there is an inadvertent vascular injection, then you're not injecting the whole bit. So always small aliquots. Every aliquot is like a test dose. You give local anesthetic and you wait for a few seconds and then inject, and you see the spread around it. The other thing that I always do is documentation, because if you don't write it, you haven't done it. So documentation is something that I do on my own. And post-op pain rounds is what we have been starting to do for all patients that have a nerve block done, or if they have the nerve peripheral nerve catheter, then they get a post-op pain round. Now, having coming to that, actually how to do the block. So this is just a cadaveric picture of the femoral triangle of the left thigh. You can see the inguinal ligament on top here, the adductor longus muscle and the sartorius muscle, that's the femoral triangle, and the femoral vessels and the femoral nerve sitting in the femoral triangle. Now, the reason for putting this is, if I were to do a femoral nerve block ultrasound guided, I would probably put the probe in that position and I would be able to see all the three structures. But you can probably make out that the femoral nerve below the inguinal ligament actually as a whole is only for a short distance, maybe a couple of centimeters. And after that, it starts giving its muscular and cutaneous branches. So you want to get the femoral nerve when it's at its full. And a rough guide to do that is to also scan the femoral artery as high as up towards the inguinal ligament to catch it as a single artery. So as a general rule, if you give the local anesthetic in the area where the femoral artery is as a single artery, then more often than not, you will catch the femoral nerve as a single nerve rather than when it has already given its branches. So I would come from lateral to medial side in plane and give local anesthetic in that area of the femoral nerve. The other thing to remember, and I think is quite important as well, and maybe cause of a lot of femoral ultrasound guided femoral nerve block failures, is piercing the fascia iliaca. Now you can see the femoral vessels here, the femoral nerve here, and there are two blue lines which are there on top. So the first blue line is the fascia lata. The next blue line is the fascia iliaca. Now you can see that if my needle trajectory comes from lateral to medial side and I inject local anesthetic in the area of the femoral nerve, I want to make sure that my local anesthetic or my needle is actually pierced the fascia iliaca. And this I can know by looking at the spread of the local anesthetic. Now, if my local anesthetic starts spreading in that direction, going above the femoral artery, then I will be pretty doubtful that I have not pierced the fascia iliaca. I want my local anesthetic to spread somewhere like that and not track up the femoral artery. Then I'm pretty much sure that the femoral nerve is going to be bathed by my local anesthetic. I've got a couple of videos there which I'll quickly go through. Now, this is what I mean by trying to get the femoral artery as a single vessel so that the nerve also is pretty much visible and you want to catch it as a single nerve. Now, before I start playing the video, just to show that this is a femoral artery, that's one of the branches where the femoral artery has also profunda femoris artery. That's the femoral vein which is squashed, and you can probably not make out a hyperechoic structure here. So you can't really see whether the femoral nerve is sitting next to it. So I try and scan towards the inguinal ligament high up and try and get that femoral artery as a single vessel and then try and look. And you can probably appreciate, if I freeze that, you can probably appreciate a hyperechoic structure which is coming into view when the femoral artery is relatively as a single vessel. So that probably gives you a better idea that the nerve is almost like whole. Now, a few points to ponder is, I know everybody says that the femoral nerve is an easy block, but I think all of us have gone through that learning phase and we still struggle sometimes because it's a fairly big nerve, but it's fairly flat as well. Sometimes lies completely flat below the fascia iliaca, lying on top of that iliopsoas muscle. So it makes it difficult to differentiate from the facial planes. The borders of the nerve may not be really difficult to visualize. So I think it's a good idea that the needle trajectory to be as flat as possible. So the appearance of the needle one is better. And the other thing is to needle entry to be as lateral as possible that you can safely do. That gives you a better idea because in case you cannot see the lateral border of the nerve, then I think it's a good idea to come from as lateral as possible. So in this video, again, I'm trying to do an in-plane needling technique from coming from the lateral side in plane and trying to pierce the fascia iliaca there. Once I pierce the fascia iliaca, I get if I'm using the nerve stimulator, the desired response. Then I inject local anesthetic, small aliquots, and you can see as soon as the local anesthetic is injected, the needle tip also is better in visualization, and the local anesthetic now you can see does not track above the femoral artery, and I'm pretty much sure that the local anesthetic and the needle has pierced the fascia iliaca and the femoral nerve is bathed by the local anesthetic there. Ideally, I would want to inject local anesthetic even below the nerve, but sometimes it is not possible, but a good 15 to 20 mils of local anesthetic, or sometimes even less than that if the spread is adequate, usually does a good job as long as you have pierced the fascia iliaca. Now coming to the lateral femoral cutaneous nerve, there are various approaches described to block the lateral femoral cutaneous nerve. Something which I normally do is, again, put my ultrasound probe in the area where I would do a femoral nerve block, and then just move it laterally to find the lateral edge of the sartorius muscle. And in the two facial planes of the fascia lata and fascia iliaca, I would put local anesthetic in plane coming from lateral to medial side. Now, a few things about the lateral femoral cutaneous nerve. It's a fairly small superficial nerve. The course is variable. Sometimes it pierces through the inguinal ligament. Sometimes it lies also inside the sartorius muscle. And there are various approaches, as I said, that have been described in literature. But general landmarks include the lateral border of the sartorius, the anterior superior iliac spine, and it usually lies between the fascia lata and the fascia iliaca as compared to the femoral nerve, which lies below the fascia iliaca. Now, I just want to mention this in this article by Dr. Thomas Nielsen. They mention about FFFT, which is a fat-filled flat tunnel, which is a triangular space that lies between the lateral border of the sartorius and the tensor fascia lata muscle. And I think that's a good a landmark to recognize, because sometimes the facial planes are so many that it becomes really difficult to make out which is the fascia lata and which is the fascia iliaca. So I'm just going to go a quick scanning video. So that's again of the left thigh, left side of the screen is medial, right side of the screen is lateral. My cursor is on the femoral artery, that's the femoral vein, and I'm going to scan laterally as the video will show. And as I scan laterally, that's the sartorius muscle, which is going from right to left. That's the tensor fascia lata muscle there. And if I just freeze that there, as per the FFT, what they mean is the local anesthetic to be injected in this triangular area, which lies on the lateral border of the sartorius and the medial border of the tensor fascia lata. And you can probably see a hypoechoic small structure, which is lying there, which probably is the lateral femoral cutaneous nerve. Okay, I'm just going to again show a quick injection video of that. So that's again the FFT, as they would probably mention. You can see hyperechoic small structures here. When I put the local anesthetic, you require just 3 or 5 mils of local anesthetic, which should be enough to catch the local anesthetic, catch the lateral femoral cutaneous nerve. And just a normal needle actually should do the trick. Just so that's my last slide, actually, just a few pearls is eyes don't see what the mind doesn't know. I think it's important to visit and revisit anatomy and sono anatomy. It is important to identify normal to be able to identify abnormal. So when you're using ultrasound, I think you should just scan normal structures first, then you should be, you will be able to identify what is abnormal. Bony landmarks and vascular structures are our guides, and they help us immensely. Femoral nerve, along with few other nerves, are have this habit of anisotropy. And so a little play of angles of the probe will enhance the visualization of structures. And again, hydrodissection is something that I cannot give importance to more. So I think hydrodissection is something that should always be done to improve the visualization of the needles and also for the structures. So a big thank you to the AORA organizing team, Dr. Ritesh doing a great job, Sonosite, Fujifilm and Anaesthesia TV. Thank you very much.
Yeah, Dr. Harshal, thank you very much for your talk. Unfortunately, Dr. Sailesh will not be able to give his talk because of technical reasons. So we will straight away move on to a question answer session, as well as comments and questions from the executive members as well. Unfortunately, we have not received any questions in the chat box as yet. So I would request any of the executive members, if you have any questions or comments, please go ahead.
Shomita, is
Dr. Amjad
around? Dr. Gopal, are you there?
Cannot.
I don't think he's part of.
I don't think so. He's there.
Okay. So I have a question on the lumbar plexus, and probably I should just make it into a comment since Dr. Gopal is not. Very often when we look at literature and articles, the term lumbar plexus block and lumbar paravertebral block are used together. So for many years, as I went through regional anesthesia, this was a point of a conundrum where are they the same entities? Can you call a lumbar plexus block a lumbar paravertebral block? And I think a couple of years ago, there was a very interesting paper by Dr. Karmakar where he used one of his fancy machines and actually looked into the paravertebral space with great detail. And he found that the lumbar paravertebral space is actually a kind of a fat-filled space, and it is a completely different entity from where we are likely to place the needle while doing a conventional lumbar plexus block. So these are two separate entities. I'm not sure whether we can call a lumbar plexus block a lumbar paravertebral block in today's age with today's imaging and today's understanding. But it's just something for everyone to think about whether these are one and the same or they are two different entities. Whether the lumbar paravertebral space is a completely different entity.
I think
Ritesh?
Siva can highlight something on it. Shiva? Hello?
Yeah, Ritesh,
I think
hear my internet connectivity is not stable.
yeah, I think you can
Am I
highlight.
audible?
Yeah, you're audible. I think you can highlight on this lumbar paravertebral because I have.
No, I'm sorry, I'm too
heard,
far away from that zone.
but I heard you are doing some hernias under lumbar paravertebral only.
Yeah, we are learning about it as previous sir pointed out. The clarity of ultrasound engine is really poor at that zone. Even when I use an export A, which has got the highest resolution in sonocyte, we still struggle. Where exactly is we are not able to see the nerve, and especially for hernia surgeries where we wanted to block L1, L2, T11, and T12, we can see only bony reference landmark. So below the transverse process to the vertebral body, where to inject is a big question. So our success rate is very variable, as I'm just told if you in the paravertebral space exactly it works. If you're not in the space, it's not working. So it's not like a brachial plexus where we can see things clearly and dissect out. It's quite deep. So I think we have to have a much more learning in paravertebral space. But as far as lumbar plexus is concerned, I'm not an expert. I don't have much experience. But yes, sir, Silas sir.
Hello. Yeah.
Sir, you have to unmute. Silas sir, you have to unmute yourself.
Can you hear me now? Yeah.
Yes, sir.
Yeah.
Paravertebral block is called as a psoas compartment block because the lumbar plexus is situated in the posterior 1/3 of the psoas muscle. The psoas muscle also has two parts. The thicker part originates from the vertebral body and the intervertebral discs. And the thinner part, called as the accessory part, which is the part which is posterior, it originates from the transverse processes. The actual plexus is between the two parts of the psoas muscle body. So, and it is in the fascia. So it is actually in the fascia between the thicker part of the psoas muscle and the thinner part of the psoas muscle. So it is in the posterior. Initially, they used to think that it is between the psoas muscle and the quadratus lumborum. And that is why it was called as psoas compartment. But that is what they were thinking, that is called as the compartment. But actually it is inside the muscle, the posterior 1/3 of the psoas muscle. Okay, which also contains the vertebral arteries and veins. So the needle has to be in the posterior part of the psoas muscle actually. Even with a nerve stimulator, and then if it is in the posterior part of the psoas muscle, then you get the quadriceps twitches. Otherwise you will not get it. So the advantage of ultrasound is exactly you can make out where the needle tip is. Okay.
Yeah,
I may be at maybe infancy, but whenever even I looked at when Karmakar was doing the real-time demo in JIPMER sometime back in 2013, he really struggled to get the twitch. Basically, if he has used the fancy machine, actually Philips U, that's the highest engine available, but he couldn't able to see the nerve roots as such, but he was searching a lot to get a twitch. Then, as you said, he landed up between the posterior 1/3 and 2/3. He has injected about 20 ml, but the block effect was not that great. So even if it is a compartment and we are exactly between the posterior 1/3 and anterior 2/3, you inject 25 ml, but still the success rate is,
there is
I don't know how.
Yeah. For that. There is one reason for that. If you see the lumbar plexus, the higher nerve roots, that is the iliohypogastric nerve, ilioinguinal nerve, genitofemoral, they are all only sensory nerves. So if you are even 1 or 2 centimeters above the at the cranial level, above the L4, then you will not get the twitches. You will not get the end motor response because they are sensory nerves. So then you have to withdraw the needle and go about 1 centimeter down, and then
to
you
go to L3, L4 level, maybe. Okay.
Then you'll be able to stimulate the femoral nerve. That is one of the troubleshootings, that even if you are in the posterior 1/3 of the psoas muscle, with you can make out from the ultrasound that you are in the posterior 1/3, still you're not getting the end motor response with the peripheral nerve stimulator. That means you are little at a higher level where you are stimulating.
Maybe L1, L2 or L2, L3 level instead of L4, L5 or 3, 4. Correct. Yes, Arshal Wag, you're trying
to. I just wanted to get what Shailesh sir just carrying forward. Even in ultrasound guided, say through a Shamrock technique, where you're pretty much sure you're at L4 and L3, L4 or L4, L5. Even when you can see the, well, supposedly you can see the lumbar plexus in that muscle in the psoas, and the needle is quite close to it. It is quite sometimes that you can't stimulate it even when you're pretty much sure that, you know, it looks like a lumbar plexus and the needle is fairly close to it. But I have a couple of times where we have injected about 15-20 mils in the area where we think, but not get the twitches, and it has not been that bad for patients who have had surgery only under lumbar plexus and a sciatic for, say, a hip hemiarthroplasty or intertrochanteric. So I don't know, maybe it works both ways.
I wanted to ask Shailesh sir, what is the success rate for surgical anesthesia through only lumbar plexus? Is it consistent? I mean, I wanted to know from the experts who are doing it routinely.
Yeah, we have done quite a few cases, high-risk patients, but only lumbar plexus is not enough for any lower limb surgery. You have to give a sacral plexus block, and that too at a higher level, the sciatic nerve, Monceau's technique.
Parasacral,
so I usually give in the same position, I give a lumbar plexus block with a standard technique where there are 3 landmarks: the midline, the posterior superior iliac spine, and the Tophius line. At that junction, and then same line from the posterior superior iliac spine to the ischial tuberosity, and the junction of the upper 1/3 and lower 2/3. You can give the sacral plexus block, the sciatic block, and then it works very well. I've done bipolar hips, total hip replacements also in only lumbar plexus, sacral plexus blocks without even sedation. Actually, I had a lot of videos also, but unfortunately,
that's okay. Unfortunately, it is not working.
Dr. Shiva,
I mean, with these,
Yeah, Dr. Shiva, we also, this is Dr. Soumita, we also keep doing all our high-risk hip and THR under lumbar plexus block, and the success is quite good if we keep the pros and cons in mind. And also, we do it as a dual guidance. I don't know how many of us are doing lumbar plexus block only with ultrasound, but we definitely use a dual guidance while we are doing
There's a dual guidance, yes.
Yes, always.
I
think with the
with only peripheral nerve stimulators, but now I do with the dual guidance. But ENS I've done maximum.
Yes.
So is just for the sake of is anyone of us doing only ultrasound? Because I'm also using PNS. I'm also in infancy. I've done only a few cases. So with the PNS and ultrasound both, I've never tried it with only ultrasound guided. Is it? I don't think it's safe to go only with ultrasound. Like experts can comment on that.
So Neha, for a while we were doing this block under pure ultrasound, but it completely depends on how well you can visualize the neural structures coming into the psoas muscle. So if you've got a fairly thin patient, good echogenicity happening, it is possible to actually identify the neural elements, and you need to be at the right level. It is possible to go in and have success with pure ultrasound rather than using, but I think even being a pure ultrasound person, I would still say it's a good idea to do this block with the PNS also, dual guidance, till we are able to image and understand it the way we should in 2021. It is a safe idea to use both PNS and ultrasound.
Just to Amjad, just I want to ask, if you are doing purely under ultrasound, do you put a transverse process view or an articular process view?
Yeah, so the core idea here is to actually study that area of the lumbar spine first, and actually look to a place where you just go off the spinous process and you can just see, yeah, you're saying, it's somewhere just before the articular process. I'm trying to share some images, Ritesh. I'm not able to share screen. Is there any permission that you could give me there?
I think it's allowed. I have not blocked anything. It's allowed.
Yeah, so the initial thing is, I think the shamrock method is a lot, I mean, it's a much better way to image the lumbar plexus now, as compared to the, the trident sign, which Professor Kamakar had earlier described. The echo, the ultrasound images are much better with the shamrock. So yes, the transverse process, you would actually want to get the spinous process and the bony landmarks out of the way when you try to do it. So again, whether it would be the articular process or the transverse, it's somewhere in between.
Why I ask this? Because once you go deeper, you lose the visibility of the needle. So if you have got a transverse process view in the shamrock, then at least the transverse process is a safety. Okay, is a safety, because if you have only the articular process view, intertransverse view, in the depth, there is no safety. If you lose the needle, which happens in the depth, there are chances that the needle will cross the psoas and it might go into the peritoneal space.
Yes, that's why I said that the reason to use only ultrasound would be having great visibility, not just of the neural structures, but with any block. Your needle visualization is paramount. You shouldn't be pushing your needle in any block without seeing it. Then if you do that, what's the difference between a landmark technique and what you're trying to do? So needle tip visualization is paramount. So there are not going to be too many patients who you can use a pure ultrasound technique on. But if you think that, the depths are okay, the patient is not too obese, you think you've got the angles going, you don't have too much bony issues, bony structures coming the way, yes, occasionally. But by default, if you're starting off, please use the PNS.
I think most of the lower limb blocks, you should always use a dual modality because they are deep blocks, especially lumbar plexus, sciatic at all levels, because we are actually not seeing the structures. So best is always to use a dual modality. We can get away with it in upper limb, but not in lower limb.
Yeah, I mean, like the upper limb, where we now, our understanding is phenomenally increased, exactly about all the structures. This paraspinal areas we have to study as a group, we all of us. So what are all the architectures of the bone, which is exactly the articular process, and then how the transverse foramen looks. And some thin individuals, we have seen the epidural and the well. I mean, Amjad also would have seen in a perfect inter-transverse process, you could see all those things. So if you have such a systematic understanding of all the images that we get on the ultrasound in the paravertebral space, and I think we can do a more objective blocks. And definitely, as Madam said, we need a dual guidance because the resolution of ultrasound is not that great at that level of depth. I think, do we have a time?
Yeah.
No, we have to next.
Ritesh, or we have to move to the next.
No,
session?
we have to go to the next session.
Yeah. Thank you, everyone. We'll now move on to the next session, and I will request Dr. Neha to take over, please.
Thank you, ma'am. It was very nice to have first session and all the discussions we had. So we'll move on to next session. And without wasting much of the time, I would like to invite Ram sir, who is a consultant at Columbia Asia Hospital, Bangalore. He is a AORA executive member, and he is a part of many regional anesthesia conferences and workshops till now. He is going to talk about adductor canal block. So over to you, Ram sir.
Hope I am audible. Am I?
Yes, sir.
Good evening, everyone. Team AORA and the regional anesthesia enthusiasts. So today's talk is adductor canal, and I'll be speaking on adductor canal block, how I do it, and also in addition to this is what I need to know about it. So greetings from Columbia Asia Hospital, Yeshwanthpur. A short history of Hunter's canal. You know, John Hunter in 1985, he was doing a lot of aneurysm surgeries, popliteal artery aneurysms, and he was ligating the femoral artery and femoral vein also. But he did it on 4 different patients. And what exactly happened was, like, the 4 patients died and the 5th patient survived, where he actually realized that he was trying the vein as well. On his name, the Hunter's canal, the adductor canal, or the subsarterial canal, which is the fibrous sheath enclosing the artery, was coined. So it is known as the Hunter's canal. Briefly going through its anatomy, I would suggest this article to be read by everyone, and this gives us a lot of information about the adductor canal and its anatomy. The Hunter's canal is an aponeurotic tunnel in the middle third of the thigh, extending from the apex of the femoral triangle, and it's in the middle third of the thigh, and it opens at the hiatus in the adductor magnus. So this is the beginning of the adductor canal, and we can see the profunda femoris much above. This is the femoral triangle here, adductor longus, the medial border, and the vastus medialis on the lateral border here. So we can see the femoral vein, femoral artery, the most consistent one, the nerve to vastus medialis, and the saphenous nerve, and the posterolateral part of the triangle. So the muscular borders are very important. This is the anterior one, which is the serratus anterior, the red star, and the lateral border, which is the vastus medialis, and the posterior one, the adductor longus, and beneath that is adductor magnus. So the proximally it's adductor longus and adductor magnus. So, and the adductor canal also consists of 3 foramen, which has been described. The superior foramen is where all the femoral vessels with the saphenous nerve enter. Then the anterior foramen, which is important here as far as the our saphenous nerve block or the adductor canal block is concerned. It traverses and pierces the vasoadductor intermuscular septum, and just at the part of the middle one. So the inferior one, the femoral blood vessels only exist. We need to understand the saphenous nerve comes much above the femoral vessels, femoral vessels in the adductor canal. So the inferior one is the hiatus, which is the muscular layer in the adductor magnus muscle. The fibrous tissue in the adductor magnus and the vastus medialis, and it forms a hiatus, and the space between the oblique and the medial heads of adductor magnus. So briefly telling about the saphenous nerve dermatome, we all know that this is the dermatome which Harshal had also put it in, and the femoral nerve supplies this part, and this is cutaneous, sensory part, and this is the saphenous nerve distribution. We can see it distributes till the ankle on the medial side, and posteriorly up to the mid, up to the angle of this thing, popliteal fossa. So this is irrelevant in osteotome because there's been on literary search also, there's no mention of any part of the osteotome being supplied by the saphenous nerve. But we know that it's a sensory nerve. Just for the completion, we should not have the feeling that it supplies any form of the bone, but it may supply the articular cartilage. So coming to the adductor canal proper, the indications of adductor canal block is the total knee arthroplasty, which aids in preventing the weakness. Adductor nerve block will prevent the weakness of quadriceps, which is commonly seen with the femoral nerve block, and any surgery along the medial side of the leg, and all surgeries below the nerve along with the sciatic nerve block. So we need to have all the gadgets available in the close vicinity in case of eventualities, and also we need to aim at a proper asepsis. What we need to know is we need to take an informed consent, appropriate dosage of local anesthetic, and the type of local anesthetic should be planned, appropriate probe, appropriate needle, and rescue medication and staff. We should not forget about the pre-procedure checklist and the consent. Most important thing is the side and the side to be marked, and we should be very cautious about not giving a wrong side blocks. So coming to the technique proper, and as we have in many other blocks, there have been a lot of studies where, papers in the past, many years ago, they have done a surface marking techniques and, infiltration. We used to do on the anteromedial surface of the thigh, of the knee, where we used to infiltrate the local anesthetics. And I think this is more of an ultrasound guided block. There's no room for any nerve stimulation because it doesn't have any motor supply, or it is a combination of that. We'll see how it is. So this is the femoral canal, femoral triangle surface marking, and A, B, C suggest the ultrasound markings. A and B are the markings, and B is the point of entry. That's the center of the adductor canal. Let us see why it is important. So the adductor canal extends from the apex of the femoral triangle, the middle 1/3 along the sartorius here, and the apex. What we see at the apex, we see the sartorius muscle, adductor longus, and vastus medialis, and the artery, the femoral artery. So next comes our the distal 1/3 of the adductor canal, where we see the vastus medialis on the lateral side, adductor magnus, and artery and the vein and the sartorius much medial to the this structure. So our point of interest is in the middle. This is where the relation between the vastus medialis, femoral artery, femoral vein, adductor longus, sartorius are maintained. So this is the point of block. This is the point where we should be aiming our block. So why? So now coming to the nerves of interest. So if you see this previous slide, here the nerve to the vastus medialis is more consistent throughout the course. So we have the saphenous nerve. It is the largest and the longest cutaneous branch of the femoral nerve, and the longest nerve in the body, nerve to vastus medialis. And there have been some papers which suggest the obturator nerve and a branch of it will also contribute. What we need to understand here is the saphenous nerve and nerve to vastus medialis forms a plexus between the femoral condyles and the femoral artery on the posterior surface of the femoral artery. And so coming to the adductor canal block proper, the value of adductor canal block for TKR in particular is difficult to assess, given that the nerves that course through the adductor canal innervate only the anteromedial joint, with the posterior innervation originating from the sciatic nerve. So this slide shows us how consistent is the nerve to vastus medialis and the deep plexus, which I was mentioning, which also gives a genicular band, are consistent in providing analgesia to the anteromedial joint. In the study which I was mentioning in one of the first slides of the references, so out of 20, all 20 had had intramuscular branches from the nerve to vastus medialis, and the deep plexus contributed to 90%, which forms the deep genicular nerves which supply the anteromedial, and to a lesser extent the saphenous nerve, which is about 55%, though it had 55% out of 20. Out of 20, 11 cadavers had this nerve supplying the infrapatellar branch, that's a medial nerve. And when we were discussing about this with the surgeons, they many times, this 11%, they even felt the postoperatively, the follow-up in the postoperative phase after discharge from the hospital in the wards and clinics, they have found there can be a small area of numbness in the medial side. Probably this could be this part of the nerve which has been cut. That's what their consensus were. So understanding the rationale why we need to inject at the midpoint of the adductor canal is that if we inject the drug at the apex of the femoral triangle, of course, there will be adequate analgesia, but there will be significant quadratus weakness secondary to rectus femoris, vastus lateralis, and vastus intermedius block. If you see this yellow structure, if you see a dissected specimen, there will be a lot of nerves which will be coming up. If you give a volume about 15 to 20, they can easily block the femoral nerve. So what is the rationale in not injecting at the lower end? Injection of large volume of local anesthetic in the distal part of the adductor canal, closer to the hiatus, can spread to the popliteal fossa, involve the branches of the sciatic nerve with varied degrees of foot and ankle weakness. And also we need to understand the saphenous nerve might have given a might have exited much above this distal end of the adductor canal. So the ideal point of giving a block, adductor canal block, is a midpoint of the middle 1/3 of the of that line joining between the anterior superior iliac spine and the adductor tubercle, or as dictated by the ultrasound. Ultrasound is considered as standard because we can, as I showed you in the previous slide. So ergonomics is most important. We can this should be the position of the operator from the lateral side, then the probe and the monitor here. So patient's leg to be slightly abducted and externally rotated, and we usually appropriate probe has to be selected, low frequency probe, and a pre-scan has to be done. We should be cautious about the patients in obese patients. And as we know, there's our orthopedic surgeons are obsessed by their dressings. You know, they can extend till the mid thigh, and we might have to squeeze it back and forth, and we should be cautious about not making the dressings unsterile as well as our catheters unsterile. So this is a single shot adductor canal block which we are giving. You can see this is the lateral end, this is the medial end, and we can see the needle coming from the lateral end towards the medial end. This is the femoral artery here. So we should be cautious about the vasoadductor membrane, which I was mentioning about. It's a thick membrane between the vastus medialis and the adductor muscles here. So this is the needle tip coming in here, and we are, as it was mentioned, the precautions like hydrodissection can be used, and be careful, and we should be cautious to see the needle tip here as we are approaching towards the artery and the vein, and I'm just dissecting here, hydrodissecting or giving a local anesthetic there, and we can see the nerve popping up here, and I'm going over the nerve, and I'm just injecting there, trying to separate the facial planes, and here is the saphenous nerve. So this single shot nerves can be, blocks can be used when we are doing any of the procedures on the medial side, if it is not approachable, as in many of the vascular cases where there'll be gangrenes in the leg and etc. So now coming to the catheter technique, we do catheters for most of the TKRs. This is the lateral side, and this is a 2V needle which we are using it, and you can see the spread, hydrodissecting, and you can see closely the catheter coming out of the Huber tip, and the spread of the drug. So you can see this is a femoral artery, and the catheter over the femoral artery. I would prefer to put it about 1 centimeter or 2 much ahead of the femoral artery, and here this is the sartorius as well. This is the femoral nerve, and once we give a bolus, it'll be bathing, and we'll continuously give an infusion of drugs. And you can even see when you're aspirating, checking for the aspirate and all, you can see the drug moving in and out of the catheter. So this is a catheter coming out, and we have to secure this catheter appropriately with or without sutures as we are convenient. We usually commonly use about 0.25% of bupivacaine, anywhere between 15 to 20 ml bolus, if at all we are giving. I mean, if it is required, otherwise many a times it will suffice to give a 10 ml boluses. Then if it is properly, you can see the expansion, and infusion of 0.1% bupivacaine 5 to 8 ml per hour is used for a postoperative analgesia. There have been some studies where they have done the assessment of the adductor canal. They have quantified it as 7.6 centimeters, 2.2 in between, to around 2.5, and the lower one about 1.5 centimeters length. And they have mentioned that about 5 to 8 ml per hour is sufficient enough to bathe the complete adductor canal with drug, and which provides appropriate analgesia. We should be aware of the complications. So prevention is better than later worrying about the complications. Accidental injury to the artery, which is very common, and we should try and do most of the times in a in an implant technique where we see the full length of the needle and the tip is seen very well. And nerve injury with neuropathy has been reported by few reports. Infection, when we're not taking about care of any of the aseptic techniques, or even otherwise if the knee gets infected, and we may be blamed. I mean, it's not the question of getting blamed, but we should be cautious about that. Last but not the least, we should be cautious about how much of local anesthetic we use. local anesthetic systemic toxicity should be always kept in mind, because most of these patients who come for the TKRs will be elderly with quite many comorbids. Take-home messages: adductor canal block is a sensory block with minimal or no motor blockade at the knee. Adductor canal block should be given at the midpoint of the adductor canal. If local anesthetic is deposited at the proximal end of the canal, it functions like a femoral block with all the quadriceps weakness, etc., etc. These are my references. Thank you.
Thank you so much. We are having a few questions in the chat box, and if you don't mind, we will take it at the end of the session, I hope.
No problems. No problems.
Please be with us, sir. Thank you for, very much for the talk. So our next speaker is Murli sir, and it's my pleasure to introduce her. He doesn't need any introduction as such, but he's working at Apollo Hospital as consultant in anesthesia and pain management, and he has delivered a number of talks related to regional anesthesia, and he's a AORA executive member. So Murli sir, over to you.
Good evening, good afternoon, and good morning. I know this is being shared across the world through Anaesthesia TV and other channels. A warm welcome to everybody who is on the other side. A happy New Year. So let me start sharing the screen. Yes. So for the next 10 or 15 minutes, we are going to be discussing the PENG block, and I thank the AORA entire committee for giving me the opportunity. So to start off with, disclaimer, no industry affiliation, and we're taken consent from all the patients whose videos I'm going to be showing. Now, the outline of my talk is to talk about the anatomical basis of this new block, the scanning technique and the sonoanatomy which is involved, the block per se as to how we do it, the indications, the contraindications, and the possible complications that we might encounter. So coming to where the entire story of PENG block started, it actually comes from the chronic pain. So people were doing the denervation of the hip for hip pain in the chronic pain practice. And what we would generally do is do an RF ablation of the anterior capsule. Now, Dr. Philip PENG from Toronto is a very interesting person because he does both chronic pain and acute pain, and he's an authority with regards to ultrasound blocks, both in acute and chronic pain. So his team from Toronto went ahead and did a cadaveric study to see what the anterior capsule is supplied by, and do we have an anatomical basis of where we can put the needle. So as you can see in this cadaveric specimen, which is explained in detail in this study, which was published in 2018, they noted that the anterior capsule of the hip joint is supplied mainly by the femoral nerve, the obturator nerve, and an accessory obturator nerve. Now, what they noted is the femoral nerve gives two types of branches to the anterior capsule. They called it the high branch and the low branch. The high branch coming above the inguinal ligament and the low branch coming below the inguinal ligament. The obturator nerve, again, they said high and low branch based on whether the branches came before the division of the anterior and posterior branches of the obturator nerve, or below the division of the anterior and posterior branches. They also noted another nerve which was called the accessory obturator nerve. Now, what they noted is that in the 13 cadavers that they examined, the femoral nerve supplied the anterior capsule of the hip joint in 100% of the patient, in 100% of the cadavers. The obturator nerve again supplied in 100%, whereas the accessory obturator nerve supplied in 53%. Now, the important thing here to note is the femoral nerve supplied in 7 out of the 13 cadavers, that is 53%, a branch coming above the inguinal ligament. So they noted that if we give an infrainguinal block, such as a fascia iliaca infrainguinal approach or a femoral nerve block, it will not be able to block this high branch. And they also noted a few landmarks with these branches. So the main thing here, which we will be seeing again with regards to sonoanatomy, is something called the iliopubic eminence, which is a bony landmark between the ilium and the pubic bone, and the anterior inferior iliac spine. And we are not going to talk about the inframedial acetabulum because that is something which we are not going to block in the PENG block. So we are not talking about this, but this is something to note, the iliopubic eminence and the anterior inferior iliac spine. So in conclusion, they said that the anterior innervation of the hip capsule is by predominantly femoral, the obturator, and the accessory obturator. Now, subsequent to this anatomic study, they described the PENG block for hip fractures. So this was the first paper which came out in the end of 2018, again from the same group from Toronto. And as you can see here, this is basically the high branches of the femoral nerve, the one highlighted in the green, innervating the anterior capsule. And this is the accessory obturator nerve. Now, main thing to note here is these sensory nerves which innervate the hip joint traverse on the bony landmark of the iliopubic eminence to anterior inferior iliac spine. So this is the landmark which they were able to identify in most of the specimens. And they did this, the paper came out with their clinical experience on patients with hip fractures and during the hip arthroplasties. And interestingly, the name is based on Professor Philip PENG because it actually is from his own team. Now, coming to the scanning technique that they described, this is what is popularly being followed by everyone practicing the PENG block. It is to scan along this bony landmark of anterior inferior iliac spine and the iliopubic eminence. So what do we see when we scan? Now, we will be seeing this bony landmark, which is formed by the anterior inferior iliac spine and the iliopubic eminence. We will see the psoas muscle tendon. We will see the femoral artery. So these are all the important landmarks that we need to keep in mind. The femoral artery, the iliopubic eminence, the pubic ramus, and the anterior inferior iliac spine. So this is how it would look when we scan the area. And what we are seeing here is, again, the same structures that are delineated in the earlier slide. So if we look at the ultrasound frozen image of this region, we'll see that the anterior inferior iliac spine is one bony landmark. The femoral artery is what we would see. The iliopubic eminence is another bony landmark, and the psoas tendon. And the target here is between the psoas tendon and the bony prominence, which is formed between the anterior inferior iliac spine and iliopubic eminence. Now, what do we see when we scan this area? If you were to go a little distal, where we have image A, we will see the femoral head, and you can see it as a nice dome-shaped structure, and the femoral artery over here. And as we scan a little bit more proximal, we will see the earlier mentioned bony landmark of anterior inferior iliac spine and the iliopubic eminence. So as everybody has been mentioning during the last hour, we definitely need good monitoring, the emergency drugs in place, an IV cannula, and of course the ultrasound to do this block. So what is the position? This block is done in a supine position. And I've just kind of marked here to highlight the different structures. So the anterior inferior iliac spine would be somewhere there, the pubic tubercle, and generally the iliopubic eminence is seen just under the femoral artery. So coming to what we would see when we scan this area. So we need to start scanning at the level of the anterior superior iliac spine. So we would see a nice bony prominent structure with a shadow, anechoic shadow. Then we'll come down to the level of the anterior inferior iliac spine, where we will see a bony shadow, but much more medial to the anterior superior iliac spine. And then we tilt the probe to around 30 to 45 degree angle to align it with the iliopubic eminence. So this is the final image that we will need to get before we proceed with the block. So coming to a video just showing the same things again. So we'll start with the anterior superior iliac spine, as you can see here. That is the bony shadow, which is anterior superior iliac spine. And as we move more caudally, you will start seeing the anterior inferior iliac spine somewhere here. And now, once we see the anterior superior inferior iliac spine, we tilt the probe to around 45-degree angle to align it with, now you can see the femoral head and the capsule, and align it in such a way that we will be able to see the anterior inferior iliac spine, the iliopubic eminence, the psoas tendon, and the pulsating femoral artery here. Now, the block requirements for this block is that we would require a curvilinear probe in most of the patients. In thinner patients, we have used a linear probe, and we normally use a 100mm block needle or even a spinal needle in certain cases because we don't need to stimulate. We earlier used to, but now we don't. And a local anesthetic of around 15 to 20 ml. Now, the ergonomics is that we do the block along the line of visual axis. So we can see that the operator is here under complete aseptic precautions, and the ultrasound machine is in line with the axis of the needle. Now, I'll just show a couple of videos of the block being performed. So this is the femoral artery here at the top. And in this, we cannot visualize the needle that well, but you can see the local anesthetic spreading. So it has been hydrolocated. So we can see the femoral head, the bony landmark of the anterior inferior iliac spine on this side, and the iliopubic eminence, and the local anesthetic spreading just above the bone. This is another video showing the needle coming in line with femoral artery here. So just above the bony prominence of the iliopubic eminence, the local anesthetic is injected to block the sensory nerves which innervate the capsule. Now, what happens to the drug? Now, this is a cadaveric study which was performed where they've shown that the 20 ml of drug spreads a little bit higher than 10 ml. So the recommended dosage would be around 15 to 20 ml in most of the patients. And the drug spread, as you know, in this schematic shows that it spreads in both the directions, upward and downward, and blocking the sensory branches of the femoral nerve, the accessory obturator nerve, and the articular branches which come from the obturator nerve from below. Now, this is the most recent paper and a review looking at the PENG block and what does it show? And they basically looked at hip surgery and hip fracture here, and the review tells us that it is a good promising regional anesthesia technique, especially for hip surgery and hip fractures. And they looked at around 30 papers, but most of them are case series and case reports. So there is no RCT or any kind of structured study yet on PENG block. So there is definitely a level of bias when it comes to the results. And it has been also used in the emergency department. There are a few papers coming out with emergency physicians using the PENG block. And also, surprisingly, even the cardiac anesthetists are using it for surgical anesthesia for vein ligation and stripping, which might be a little far. It might not be the right block for it, but there are all other kinds of indications which are coming out. But I believe that it is an excellent block, mainly for hip surgeries. So, is it a safe block? Now, coming to the differences in anatomy, there are a few questions which have been raised on the variations in the male and the female pelvis and the angulations that are required for doing the block. And we have to be extremely careful doing it in the pediatric age group because the bones are not yet formed and therefore the structures might not be where they're supposed to be. So this is something which we need to keep in mind. The other word of caution, which has been mentioned in some of the case reports and letters to editors, is that the bladder and the ureter are in close proximity. The ureter probably is not that much because it enters the bladder posteriorly, but a full bladder in a patient who is undergoing this block and not seeing the needle tip can lead to bladder injuries. The other word of caution is while going through, we need to make sure that we have visualized the femoral nerve and we don't pierce the femoral nerve and cause inadvertent neural damage to the femoral nerve. So when we started doing this block way back in 2019, I got introduced to this block by Dr. Amjad's talk in AORA 2019 and came back home and started doing it. The first 10 patients that we did, we had wonderful results, as you can see. We did it actually as an on-arrival block. The patients would get the block immediately on admission to the hospital. And you can see that the VAS scores were close to 9 or 8 in most of the patients. And 20 minutes after injecting around 15 to 20 ml of 0.5% levobupivacaine, you can see that most of them had a drop of close to 7 or 8 in their VAS scores, which is very significant and probably one of the best drop in pain that you can see in any kind of intervention for hip fracture analgesia. And we also followed them up to 12 hours and 24 hours, but I can tell you that the analgesia lasted for more than 12 hours in most of the patients, and positioning them for a spinal the next day was actually a dream. So they did not have any pain. So we did this initial audit of 10 patients, presented to our orthopedic team, and now it becomes a routine practice that all patients who come in with hip fracture are given the PENG block on arrival. And this has become a routine with regards to our practice in Apollo. So coming to the summary, it's definitely a new promising block. And mainly, I would say for hip fractures and less for everything else. And I've highlighted pre-op here because it makes the entire stay of the patient completely a different ballgame, because they're comfortable from the time you give the block, and they get positioned for X-ray and everything very comfortably. Post-op analgesia, again, it plays a key role if the block is given quite close to the time of the surgery. But we need to see more studies on safety and efficacy, especially some kind of control trials coming out, which will give us more data. And I would leave you with the last slide, telling that all of us are getting old. And in the next 20, 30 years, as you can see this slide, we'll see an aging population with more hip fractures coming into our ORs. And probably this block will be a game changer. Thank you.
Thank you so much, sir, for the detailed discussion of this relatively new block, I should say. So after adductor canal and PENG discussion, we'll move on to suprainguinal fascia iliaca block. And I would like to invite Rupinder ma'am for that. She's working as professor in Dayanand Medical College, and she's an AORA exo. Over to you, ma'am.
Thank you, Dr. Neha, for that introduction. I hope my slides are seen.
Yes, ma'am.
Yeah, okay. So today, at the fag end of this webinar, we are going to discuss the suprainguinal fascia iliaca block, how I am doing it. So it is fashionably called as the SIFI block also. Basically, Dr. Murli has little bit made my work a little easier by talking about the anatomy of the hip joint as such per se. So basically, this block has got its implication in both pre and post-operative, especially in geriatric group of populations, fractures with hip and proximal femur, and definitely in patients with total hip arthroplasty. Various studies have shown that this suprainguinal fascia iliaca block provides a very high quality analgesia, not anesthesia, but it provides good high quality analgesia. And this analgesia is very important in geriatric group of populations because post-operative delirium is a very common phenomenon in them. So it decreases the incidence of post-operative delirium. And of course, the systemic administration of opioids and fewer side effects. If you're giving an epidural, there'll be definitely less amount of side effects than with epidural anesthesia. So just a basic about the anatomy, what we are trying to, why do we want to do this suprainguinal fascia iliaca block? The basic aim of doing the suprainguinal fascia iliaca block is to block these three important nerves, that is the femoral nerve, the obturator nerve, and of course the lateral femoral cutaneous nerve at the point of origin from their lumbar plexus. So as you can see that this is the anterior superior iliac spine, and this is the pubic tubercle, this is the inguinal ligament, and these are the nerves which are coming from the lumbar plexus. So our aim is basically to insuate our needle from below the inguinal ligament. However, the tip of the needle will be above the inguinal ligament, and the drug deposition is going to be into the bowl of the pelvis so as to give a volume block over here and to catch mainly the femoral and of course the obturator, which was left behind by the infrainguinal fascial iliaca approach, and of course the lateral femoral cutaneous nerve also. So basically, who was the guy who basically came up describing the suprainguinal fascia iliaca block was Hebard. He, in his landmark paper in Anaesthesia in 2011, he did a, it was basically a 1 year kind of a study he did in 150 patients. And then he collaborated these findings on cadavers. And he found that this technique was very, very, very efficacious. And he found when he did the cadaveric dissection, he found that the dye was had stained the lateral femoral cutaneous nerve, the femoral nerve, and even the ilioinguinal nerve. In his study, he, however, mentioned that obturator nerve was not targeted. So there are various modifications and various ways by which you can do the suprainguinal fascia iliaca block. And how I am practicing it is by a technique which is known as the hourglass appearance technique. I am basically doing the ultrasound guided approach. So the hourglass pattern recognition, it simplifies the fascia iliaca compartment block. And as with all the blocks, the ergonomics is very, very important. The recognition of the hourglass. Now, what is this hourglass? I'm going to talk about it. The needle insertion point and the satisfactory local anesthetic deposition is very important. So this is just a kind of a description of the ergonomics of the block. And you have to start scanning from you basically, usually in a thin individual and even in an obese patient, you take a high frequency linear probe and you start imaging from the anterior superior iliac spine. The probe is kept in the parasagittal plane and you start seeing this structure. The ASIS is seen as a hyperechoic structure. Now you start moving your probe from the ASIS and come down to the anterior inferior iliac spine, and the Kevlar end of the probe is directed towards the umbilicus. So once you direct the Kevlar end of the probe towards the umbilicus, you start seeing certain structures, and you will be able to see the ilium. The anterior inferior iliac spine is not seen over here, but in few cases you will be able to see. So the exact location of your probe is this way. From ASIS, you go medial and you come above the inguinal ligament, and the direction of your probe should be towards the umbilicus. And this is the picture actually which you're going to see, which is a kind of a hourglass. If you can appreciate over here, there is a muscle over here which is tapering down, and there is a muscle over here. So what are these muscles? You can see a bony prominence over here. So this is the ilium. This is a big iliacus muscle over here. And if this is my Kevlar end, this is the internal oblique, and the caudal end is the sartorius muscle. So this is actually the picture which you're going to see, the hourglass appearance, which makes your giving of this block very, very easy. Another marker, another important structure which you're going to see when you're doing this scanning is the deep circumflex iliac artery, which is seen superficial to the fascia iliaca. And this becomes a very important landmark. I'll tell you how it becomes a very important landmark. So this is a small video. So you can see over here, the deep circumflex iliac artery, you can see the muscle over here. So coming on to the procedure. So this is the final procedure, the final position of the probe which you have. The needle which we use is a 100 millimeter sonoplex needle which we use, and the needle direction is in plane. So the basic aim is you have to pierce the skin subcutaneous tissue, you have to pierce the sartorius muscle and pierce the fascia iliaca and deposit the drug in the plane in between, just below the fascia iliaca as such per se. So as you can see, the needle is coming from the corded end, and I can see the tip of my needle is over here, but it has, now this is my fascia iliaca, but the needle tip has overshot it. So usually, because the fascia iliaca, because of its tensile strength, the needle usually overshoots this fascia iliaca. So you have to withdraw the needle, might be 1 to 2 millimeters away, and then you have to deposit your drug. So this is the final picture. Once again, as we can see, you can see the hourglass appearance over here. You can see the internal oblique, the sartorius, the fascia iliaca, the deep circumflex iliac artery, and the iliacus muscle. So this is a small video. So as you can see over here, this is the corded end and this is the Kevlar end. So you can see the needle is going to come from this side, from the marker side. This is pointed towards the corded end. So the needle is coming, and I'm going to pierce this bright hypoechoic structure over here. And there is a sudden pop, and then I'm going to inject. So I can do some hydrodissection at this point by 1 to 2 ml of local anesthetic, so that I know that my plane is correct. And if my plane is correct, then the iliacus muscle is going to become depressed or go down. So very important is to have a proper plane wherever you are injecting your drug. So now the question arises that how much volume you have to be given. Volume can be anything between, some studies say 30 ml, some says 40 ml, some people have been using 20 ml also. We have a study going on over here in which we have divided the patients into 3 groups, and we are giving volumes of 20, 30 and 40 ml, and we are still in the process of seeing the results. Coming on to the complications of this block, if you go too close to any of the vessels, it can cause some intravascular injection. Local anesthetic toxicity, you have to determine the milligram per kg body weight dose. And since this is an analgesic block and not an anesthetic block, you can go down on the concentration of the drug and be in the safe limits of the dosage. Intramuscular injections are very, very common, so you have to be very careful. And of course, if you go too deep, you can go and puncture the peritoneum and go into the intra-abdominal organs as such per se. So the key learning points of this block is you have to identify the hourglass pattern, though there are various other methods of also giving this SIFI block, but the most commonly used method, which I use over here, is the hourglass pattern, because we have seen that the success rate is very good and you are in the right plane absolutely. And sometimes it may be difficult to advance the needle into the suprainguinal local anesthetic pocket, as I told you, because of the fascia iliaca's shallow depth, the tensile strength, and the initial flat needle approach. So sliding the probe Kevlar prior to the needle entry such that the needle pierces the skin closer to the inguinal ligament may lead to a better angle of advancement. And the deep circumflex iliac artery is seen just posterior to the internal oblique, and it is a helpful marker for the local anesthetic spread. And the pocket of your local anesthetic should be below the vessel. And of course, it should be definitely above the iliacus, and the spread should be Kevlar. And sometimes it so happens that the anterior border of the iliacus may appear very ill-defined compared to the hyperechoic fascia iliaca above it. So you have to ensure that the local anesthetic spreads along its anterior edge so as to move the local anesthetic more Kevlar as to avoid intramuscular injection. So this was all about fascia iliaca, suprainguinal fascia iliaca block. Thank you very much.
Thank you so much, ma'am.
Hello, Neha.
Yes, sir.
Let their first session some questions which are.
Yes, you can take those questions.
Yeah, Somita madam will ask those questions. After that, we'll move to the second session question answers, which you will.
Okay.
Somita ma'am.
Yeah, sure.
Ma'am,
Yeah.
kindly Rupinder ma'am, kindly stop your screen share.
Yeah.
Dr. Salish, are you around?
Oh, yeah, I'm on.
Yeah, Dr. Salish, there are a couple of questions for you.
Yeah.
The number one question is, distance between the transverse process and the lumbar plexus is exactly 2 centimeters, irrespective of the BMI and the gender. So we can use this distance during both ultrasound guided and PNS. So they want to know your views regarding this. Is it right or not?
Exactly. You should never go more than 2 centimeters, because there have been multiple studies where they have found out that actually the average is 18 millimeters actual distance, no matter how fat the patient is. The actual distance between the transverse process and the posterior part of the lumbar plexus is never more than 2 centimeters. So if you go beyond that, you can either damage the kidneys. Kidneys are very close, or you can go intravascular, even IVC, or even aorta. So you can go intraperitoneal if you go beyond that.
So in other words, if you're going beyond 2 centimeters, that means you need to revise your landmarks.
Exactly. Yeah. So what I used to do, when we didn't have an ultrasound machine, only with a nerve stimulator, and even I think NCBI has done a lot of studies where instead of using a 22 gauge stimuplex needle, they use a 25 gauge spinal needle, which is very thin, which is there are less chances of damaging the structures. So with the spinal needle, go at L4 level and just hit the transverse process. Usually the transverse process is between 5 to 7 centimeters from the skin. So you hit the transverse process and you exactly measure how much distance you're going. And then you can, in the same direction, you put the stimuplex needle and just go 2 centimeters beyond that, not more than that. Then you're safe.
Sure.
They used to try with a 25 number spinal needle. We used to do that earlier.
Yes. Yeah, the next question, Dr. Salish, is the drug doses for lumbosacral plexus block as a sole anesthesia for lower limb surgery.
See, lumbar plexus block, first of all, cannot be given as a sole anesthesia for lower limb surgery. You have to give a sacral plexus block also.
Yes.
But lumbar plexus block can be given for post-op pain relief after hip surgeries and all. And if you want to give a dual block, any hip surgery can be done, even any lower limb surgery can be done if you give a dual block. And what I do is, for post-op pain relief, I use 0.2% dropivacane. But for actual surgical anesthesia, if I want to give lumbar plexus as well as a sacral plexus block, what I do is I use for the lumbar plexus maximum 30 ml. I don't go beyond that. And out of that 30 ml, if I want the block to last longer, I use 20 ml of 0.5% bupivacaine and 10 ml of xylocaine with adrenaline, 2% xylocaine with adrenaline. And I use additive as Decadron, 4 milligram. And if the patient is not on beta blockers, if the surgery is going to last longer, then I use Clonion, half ml, not more than that. If the patient is not on beta blockers, there is no bradycardia or anything. But if I want to give a dual block, then I calculate the dose according to the weight of the patient. And then give, I add saline also and dilute it a little bit and then give dual block in the same position, lumbar plexus as well as the sacral plexus. But I don't go beyond 30 ml, because if you go, and even the pressure while injecting is most important. If you have a pressure monitor, injection pressure monitor, then you should never go beyond 15 ml. If you go at 20 psi, if you go beyond 20 psi, definitely it goes medially and then it can become epidural or total spinal. And it can block the contralateral sensory as well as the motor. And then hypotension occurs and then the whole purpose is lost.
Yeah, that's a very valid point, Dr. Salish. The person actually who's injecting the drug when you are doing the block is the most important person. And that's why, that's why we get hold of a very experienced guy who keeps giving the drug to inject the drug for you. Because most of us, we don't have the injector monitor. Okay. So another question by Dr. Valmik is, what all surgeries can be done under pure lumbosacral plexus block?
Any lower limb surgeries can be done under lumbar plexus, sacral plexus blocks. Only thing is sometimes for hip surgeries, hip replacements, if the incision is little higher than the region of the iliac crest, that region is usually spared. So then you have to give local infiltration along the iliac crest for the subcostal nerves. But otherwise, with lumbar plexus and sacral plexus, you can do any surgery of the lower limb.
Sure. There were a couple of questions for Dr. Surajit, but he's not available. I'll just read the questions. He has sent some response on WhatsApp. The first question was by Dr. Ruchi. She wanted to know if we are doing a femoral shaft fracture under femoral nerve block with spinal anesthesia in children, does it create problem when spinal effects wear off after 60 minutes? So Dr. Surjit had actually sent a reply that when the spinal anesthesia wears off in the children, the pain, it will be pain which will require sedation and which can cause an airway compromise. So as we are routinely, he's not a pediatric anesthetist, he's practicing FNB in all ages. And by giving the femoral nerve block and the subarachnoid block, they are extending the analgesia without heavy sedation or requiring airway manipulation. Another question which was asked by Dr. Prashant was for tension band wiring in patella. He wanted to ask Dr. Surajit if his surgeons were using tourniquet and not. But he is one of the lucky person in which the surgeons don't use a tourniquet for a tension band wiring, and that's why they can get away with infiltration as well as a femoral nerve block. So that was all about the first session. I think Dr. Neha, you can go ahead with the questions regarding the second session.
Okay, ma'am. Ram sir is there with us.
Hi, I'm there.
Yes, sir. So, Dr. Harshal has asked a question regarding the adductor canal block. Like, are you routinely using a low frequency probe for adductor canal block?
Yeah, we can divide it into two things. When I'm putting a catheter, if the structures are not seen in a low frequency, and you have to, if you have to use a higher frequency probe, that means the threading the catheters can be difficult. The patient will be very obese, and the depth can be anywhere between 6-7 centimeters, and threading in a catheter can be difficult. So, we need to assess the patient, and definitely single shot blocks can be given with a low frequency. But when we give a single shot block, it is when we want to have a femoral also. Most of the times, if it's a debridement of the foot or below knee amputation or something, or even sometimes above knee amputation and everything. So then you can use a low frequency as well in the higher ups. So, that's what the rationale is. We have found a lot of difficulty in putting a catheter with when the adductor canal is very low. In my presentation, if you see, I clearly mentioned we should be cautious about the obese patients. It's very difficult to thread in, and failure rates are quite high. We'll just see the fat and nothing else. So that's my rationale behind it. Of course, I didn't discuss in detail which probe and how much is the depth and all because of the shortage of time. This comes under a general basics about how to select a probe.
The question which I had is there any particular reason? Sorry, Dr. Neha, is that okay if I?
Yeah.
Any particular reason why you thread the catheter?
That threading a catheter, we practiced it for the reason that if you see the depth of most of the patients, it will be about 2.5-3 centimeters. And if you do it in plane, this problem we had it with our even the femoral catheters also. And what happens is even theoretically also there have been studies where they have said it has to be threaded about 1 centimeter or 2 beyond the artery, so that it totally circumferentially bathe the artery around that nerves and also the saphenous nerve on this side. That's one thing. Next thing is it will be too shallow a depth. So we should have a trade-off, and we see, and the end point is not how much of length is there. It should be a trade-off between the how much length is inserted and also the spread along the artery or the nerve. So, and when I was referring about this, there's a reference for this where they say about 1 centimeter or 2 beyond the artery or beyond the nerve. So if you see that, I mean, that was one of the very standard block which I showed, I mean, which I projected, but it won't be so picture skew always, but it is going beyond. We use an epidural catheter, not the single this thing catheter. So the one orifice will be on this side, one on that side. So it totally engulfs the artery along with the nerve. Yeah, that's the main idea, nothing else. And as I was telling you, the length of the catheter, it will be about 5 or 6 centimeters. Definitely it will be leaking, and it has to be, if you don't fix it properly, don't tunnel it properly. And I didn't go into the details of how we do it, but tunnel it properly, then there can be chances of dislodgement of the catheter if it's not fixed. And also there can be a leak. So what we do is we'll take a purse string like suture along that with a sleeve of the skin, so that it just prevents that from happening. So
Ram.
Yep.
Dr. Tesha.
Yes.
So basically, what are the surgeries where you give only adductor canal blocks?
Yes, adductor canal blocks. Yes, as I was telling you, we do often practice for the TKRs. Then sometimes if it's a below knee amputation where there is no scope for giving any other distal blocks, then you can give it as a single shot in the adductor canal. I mean, or only with the femorals.
So do you add anything?
No.
Any other block in TKR apart from adductor?
Yes, we do add. We give a single shot sciatic now, anterior approach of the for the sciatic now.
Now my question is, in your presentation you just mentioned that if you inject in the lower down, the drug might go posteriorly into the popliteal plexus.
Yeah.
And the patient might have foot drop.
Yes.
But if you are giving for post-op analgesia, obviously you are giving for post-op analgesia, 0.2% ropivacaine, even if it trickles down along the adductor hiatus, is it possible to cause that much of foot drop that the patient will not be able to mobilize?
Yes, this recurrent, this 0.2% of rocuronium is, sorry, ropivacaine is something, ropivacaine is something which is, there are a lot of, sparing of motor blockade and this thing. But in our experience, what we have observed is even there is a very unsatisfactory analgesia also with that.
I disagree. I disagree with. I'm sorry for that. I disagree.
No problem. No, we less often use that
because the technique which I practice is which I have published and which I am using in my TKR patients. It's a modified 4-in-1 block. And regarding the nerve to vastus medialis, it's never consistent in the adductor canal. In maximum patient, you will find the nerve to vastus medialis out of the adductor canal. So we are blocking the nerve to vastus medialis separately, and at the lower end, we deposit perivascular the drug, and that to only 20 ml. And after 4 hours, I make my patient mobile.
Yes, Ritesh, I totally agree with your study. I went through your study, but but if you see the reference which I put it on there in a cadaver study, and there are a lot of other papers which says that vastus medialis, after giving it muscular branches, they form a plexus between the saphenous nerve posterior to the femoral artery in front of the femoral or that lower end of the femur. So this plexus will supply the anteromedial surface of the thigh. So definitely in that particular, in that particular study and other corroborative evidences also in the cadaver dissections, and there is one more study by Tobbs where they have even dissected how it spreads. This I didn't go into the details because that vasoadductor membrane which is present, that's a tough membrane which is formed. It will have fenestrations in the posterior side. So what they say is the plexus between the vastus medialis and the saphenous nerve is the one which helps us in analgesia. So it depends on our we as far as our institute is concerned, we are uniformly using 0.1% bupivacaine. Coming to your question of whether your ropivacaine, whether it can be helpful, it can be helpful. We are using 0.1% bupivacaine for a lot of reasons. We put quite a few catheters, and to keep it as a uniform drug in the postoperative period for the nurses to manage, we use only bupivacaine. Next thing, evidence to whatever you are telling also, if you see, I was telling you about the length of the adductor canal. In one of the studies, what they have done is they have said that the length of the adductor canal is about 7.6 in the pupils or the cadavers what they studied in. So it will take up a volume. If I say about 5 to 8 ml per hour, we are not giving boluses. 5 to 8 ml per hour in the adductor canal in the proper place, that is in the mid adductor canal, it will prevent all these other unexpected or unusual complications. Of course, you may ask me, why are you giving sciatic nerve block, anterior sciatic nerve block, single shot? That is to tide over the acute pain, immediate postoperative pain. Most of our patients will be elderly, and we just give this pain, and we have been practicing it from the last 11 to 12 years now. Fortunately, we don't have a foot drop or this thing which has stayed for long. But when we have discussed with other people, like Dr. TVS and all, they had a few cases which troubled them. So it is not free from any complications. It is there. We have to keep a chance, and that's where we have a very streamlined post-operative rounds, and where we look upon all these things.
Can I just put in a word there?
Sure.
Just in respect to the catheter, that 1 to 2 centimeter past, the neural structure or past whatever, is a very arbitrary figure that has been in our journals for a very long time. Now, when you do an adductor canal block and you're looking for that pure saphenous kind of block, maybe a bit of the nerve to vastus medialis, the key component here is to use low volumes. You cannot expect those characteristics that you expect from an adductor canal block to stay with giving 20 mils of local anesthetic. It's going to spread all over the place. The same holds good when you try to place a catheter and you want those acute properties of a good adductor canal block. The catheter needs to be laid in very dry, and it also needs to be placed much, much closer to the neural structures than this 1 to 2 centimeters. The moment you start putting a cath 1 to 2 centimeters past the neural structure, you're going to get a catheter that actually demands a lot more volume, or a catheter that requires frequent bolusing. So I think we should, in this day and age, stay away from arbitrary figures like that and look to position the catheter with visual accuracy very close to the neural structures.
I just add on, Amjad, here. See, that's what I was saying. When you see we need to see the spread. Basically, it is not the length of the catheters. It can be even more shallower. So it depends on the spread and appropriate spread. And we can keep on threading the catheter. It goes in, but appropriate spread, which is just sufficient enough to cover that area. That's what there have been a lot of values like 1 centimeter, 2 centimeters. They're all arbitrary. I agree with him.
So what happens when you start injecting through a catheter that is about 2 centimeters, and 2 centimeters is huge distances in terms of ultrasound. When you start injecting with a cath that is far away, you wait for that fill to actually trickle back. And by the time it's done that, you've injected a whole lot of whatever volume, whether it's saline or local, and you actually get a false sense of a fill. And once this sort of reservoir of local anesthetic depletes, you will get a catheter that is demanding 7 or 8 or 9 mils of local anesthetic or requiring bolusing in the post-op. The idea is to keep that adductor canal very dry with very low volumes, and then you have that kind of complete sensory sort of block with the quadriceps intact. So again, like I said, I would place this block very dry, very accurately to get the characteristics going.
So in addition to that, that's that 5 to 7 ml, if you give a small bolus and allow it to cover the space and add on with a very minimal dose. What we do is we'll start around 5 ml so that we can have another 2 ml on either side. So I think that is more convincing.
Can I just ask? Yeah. The question is open to everybody actually. As per the anatomy in the adductor canal, the canal has the nerve to vastus medialis as well as the saphenous nerve. Is it necessary to stimulate the nerve to vastus medialis when you're doing a proper adductor canal block? Because I think if you put enough volume, that is going to catch both the nerves. Am I correct in understanding that?
I will answer this question.
Yeah.
Basically, the if you are the nerve to vastus medialis usually takes off. If it takes off, it just at the start of adductor canal, just before the start of adductor canal, in patients, some patient whom the vastus medialis is not part of the adductor canal, it takes out, goes out. It is never part of the adductor canal, so it goes just at the start of the adductor canal. So if the volume where I inject, what we saw, the spread of the drug is only till the start of adductor canal. It doesn't go to the femoral area also. That is one advantage of the block which I am practicing. So to catch hold of the nerve distal, and I stimulate the distal end of the nerve to vastus medialis, which becomes a medial retinacular nerve and which supplies the enteromedial part of the medial retinaculum and everything. So to be very specific, so that I get a good analgesia of that medial aspect, I stimulate the nerve to vastus medialis and give around 5 centimeter, and the rest drug is deposited perivascular. So the drug spread doesn't go so much high up that it is going to catch the nerve to vastus medialis in the femoral area. That is the whole concept.
Murli sir, are you there? Regarding the PENG block, any experience
Yes, I'm here.
in catheters on additives?
No, we have not actually done anything of that kind. We have been just very careful with using just 0.5% levo, and we have got excellent pain relief. In fact, you should see the patients. In fact, after the PENG block, they're quite comfortable, and they spend a very good time preoperatively without pain, and even postoperative analgesia has been pretty good up to 24 hours. With regards to adding anything with the block, one thing which people did question was whether we can add dexamethasone. But the safety of putting a steroid next to a joint, especially when they're going to undergo a surgery, is something the surgeons are not very happy about. So whatever we practice, we discuss with the surgeons, and it has to go through the entire surgical team before we start doing block. So we present during their clinical meeting, and we take a collective decision. So right now, we are not adding any additives, and definitely we have not put any catheters. I'd be happy to hear from anybody else if they use catheters in a PENG block.
On arrival, you are depositing how much volume approximately?
15 to 20 ml. See, most of these elderly patients are pretty frail and probably weighing only 30-40 kilos. So we can't exceed with regards to their total dosage. So we are limiting our dosage to 15 to 20 ml. And we are immediately on admission, as soon as the patient gets admitted in the ER, the patient is moved to the recovery room where we do the block, then they go to the ward. So, there is a nice process which has been set in place now, and everybody is happy with the outcomes so far.
Dr. Murli, I have a question to ask you. When
Yes,
you're
please.
using this block for post-op analgesia, at what point of time are you giving this block?
Now, most of the time we tend to give the block preoperatively. So we don't use it as a block after surgery. So say if we have missed this patient, in the sense we are not given the block on arrival, we tend to give it, say, half an hour, 45 minutes before we take the patient into the OR. So it will help positioning, moving the patient. And if we're giving a general anesthetic, we tend to do the block after the general anesthetic if we are inducing the patient on the patient's bed. But invariably, we tend to do the block preoperatively. And post-op analgesia it lasts for up to 24 hours without any issues. So what we have experienced is the earlier we were using fascia iliaca block. Now the outcomes what we have seen with PENG block, it definitely overrules the fascia iliaca. So I encourage people to start using it and seeing the difference themselves. And then, in fact, I got inspired by Amjad after his talk in last year's AORA, not last year, 2019. So that's when we started practicing it from July onwards. So we have had a good experience so far, and I would like to hear if others are using it.
Yeah, even I got inspired from him, and then I gave a study to one of my students. But unfortunately, our results are not that good. Some patients, they do require tramadol on a regular basis. I don't know if the audience can.
Yeah, even in the
Can put some
audience,
more
we
light
get
on this.
also Rupinder man. Yes, Ritesh, can I?
Yeah, please.
Yeah, we are now. I think like what I'm discussing now maybe correlates with what Ritesh also pointing out in adductor canal. I mean, slowly the dynamics of peripheral nerve blocks is far away from the facial plane blocks. For example, if we are conducting a study where we are looking at the dynamic pain relief for positioning between three groups. One is a PENG, another one is a suprainguinal fascia iliaca compartment block, and another one is a femoral and obturator nerve block. The femoral and obturator nerve block, we will inject 10 ml into the femoral nerve, 10 ml into the obturator nerve. That is very high approach before it start dividing like Taha's approach. The patient, you can make the patient sit in 10 minutes, average. PENG block will take about 30 minutes, and the quality of analgesia is 10% of your peripheral nerve block. The fascia iliaca compartment block is in between the two. So this we have done only about 20 patients, but this femoral and obturator nerve block I am doing for about 4 or 5 years. So because we cannot wait for 30 minutes before spinal for positioning. So doing a peripheral nerve block is far, far away. So like as well as in the adductor canal, you will simply miss the nerve to vastus medialis if you don't see it and then inject it. And if you give a specific local anesthetic around the nerve to vastus medialis, the quality of analgesia is definitely different. After I discussed with Ritesh and every single patient, I try to see the nerve to vastus medialis. It is at least in 9 out of 10 patients, it is off the saphenous nerve. So I think as a regional anesthesiologist, yes, the facial plane blocks and compartment blocks we can do whenever we are not able to see the nerves clearly, but we should be moving consistently towards the nerves than getting satisfied with the facial compartment. I mean, that's my humble. I mean, if I look at the bigger picture, it may be different, but PENG block doesn't provide intense analgesia for positioning less than 20 minutes. Definitely not. Or the quality is very big difference. Maybe in a chronic pain, when you put a block after 30 minutes or 45 minutes, this what the volume we are using is 20 ml of 0.25% bupivacaine. Maybe as Murli used a 0.5% levobupivacaine, higher concentration, 20 minutes it may act.
No, we are definitely waiting for more than 20 minutes. We are not giving it in the OR. So we are giving it in the recovery room.
Yes.
And waiting more than 30 minutes.
And then position by the time it may act.
Yeah, so what we are seeing is many of the patients who come previous night are posted next day for a hip surgery. So when they have the PENG block done the previous night, the levobupivacaine, which is 0.5%, is working for 12 to 16 hours. So the next day when they come, positioning is actually quite easy. That has been our experience so far.
Yeah, Murli.
Yes.
Regarding the post-op analgesia,
yeah.
Are you adding any other block apart from PENG?
No, in fact, what is our practice? Like, let me tell you where we are coming from. LIA is a very popular technique with our surgeons. So we tend to use LIA. We have been using it for 3 years now. So the thing with TKR now is we do an adductor canal, IPAC, LIA. So they're extremely comfortable. So hips, they get a LIA in addition to example now, if we have done a PENG block, they will get a LIA the next day when they are undergoing a bipolar. But if they're doing a PFN or any other kind of procedures, they don't get a LIA. So we are not using anything in addition to the PENG if we are given the PENG. But if the surgeons are opening the joint and are doing a bipolar hemiarthroplasty or a total hip, they will get LIA in addition to it.
But what about the dermatomal pain, the incision pain?
Well, we haven't had so much of a requirement from the orthopedicians requesting us to kind of, look into this further. And even our post-operative rounds, especially with the hips, patients have been comfortable. It's there have not been many questions raised as to post-op analgesia and we need for tweaking. So this is where we are right now.
Okay, because if you see the incision area is nowhere
Correct.
covered by any of the nerves which you are blocking in PENG.
Very true. But
And
I think, yeah,
it's a big incision.
So that's the thing. So when they use LIA, they will be infiltrating those areas. So any open surgery, we are using LIA, and in the LIA cocktail, we are using ropivacaine 0.2%, morphine, clonidine, and ketorolac. So this is done at the level of capsule, above and at the level of skin.
So when you are doing a PENG, when you are removing your needle, just in that same window, just before the fascia lata,
Lateral cutaneous.
Yeah, lateral femoral cutaneous will be blocked.
Yes, yeah. So
I think the key to the PENG block is to use it very selectively in certain surgeries. I do not expect the PENG block to work miracles in a total hip replacement or something,
no, it
as
won't.
we said, where they've completely opened up the the entire joint. But for some of the slightly invasive surgeries like a PFN nail or a DHS, something like that, you can consider using the PENG. It is not a one-stop solution for everything that is hip. That is very clear. But you need to use it very selectively. It's just another weapon in your in your arsenal that you can have. It's quite useful. It's definitely a useful block to have, but it's not everything. It's definitely not everything.
Yeah. In fact, the thing I was selling in the entire talk was it's an excellent preoperative tool, preoperative block, on arrival block, because you're not operating on this patient for next 24 hours, and that gives quality analgesia for preoperative period. I don't think it can be, as Amjad is mentioning, an intraoperative or postoperative solution, an entire package, but it's a good preoperative block, and it's a safe block in the sense there is a bony landmark, there is a bony endpoint, and therefore, if we know where the needle is on the trajectory of the needle, it's difficult to actually damage any very important structure. So I think it's a good preoperative block for analgesia.
Yeah, Murli, in your presentation, you showed two approach to get that bony landmark, the typical bony landmark.
Correct.
One from below up and
femoral
one,
head,
and one from anterior superior iliac spine. So which is the approach you follow?
Now, the beginner's approach, what I would say is the easiest is you go from anterior superior iliac spine, drop down, see the anterior inferior iliac spine, turn the probe, and then you can visualize this bony path. Now, if you are well versed with the anatomy, you can start from the femoral head and come up, which also is very easy. It's time saving, basically. So for people who have done chronic pain or who are assisting surgeons for hip aspiration or hip injections, if you can identify the capsule, it's extremely easy. You can just move above the capsule and you'll see the acetabulum and the idiopubic eminence. So both the approaches are acceptable, but the main thing is you should know that you should not be above that idiopubic eminence or the pubic ramus, because then you'll be in the pelvis. So I think people need to, if they go down, it is safer. So if you are actually lower down, you'll be much safer than going higher up. So whenever I'm teaching the registrars, I tell them that it would be safer if you are actually a little bit caudad rather than keflad, because then you are probably close to hitting the bladder or any other pelvic structure.
Yeah. And even if you miss that typical bony landmark, you can deposit on the femoral head and it becomes a iliopsoas plane block.
Yes.
Can I ask one question?
Yes, sir, please.
Yes, sir.
I don't know. I have heard, I don't know whether it is true, that as you said, local infiltration, intra-articular, use ketorolac. But there are some surgeons who say that ketorolac causes damage to the capsules and then the joint becomes loose, the implant. So has anybody heard about it? I have no idea. So there are some.
So the local infiltration, what we practice is not into the, now example, I mean a TKR, you're basically removing all the cartilage. And what they're injecting is basically into the ligaments and other structures surrounding it. So there are specific points which they inject into. So they're nowhere close to the bone or the cartilage structures.
30% has to be injected in the posterior capsule, which is the most painful part for TKR.
So what we are doing is we are avoiding the posterior capsule injection. The reason being injury to the popliteal artery. So the surgeons are not happy injecting the posterior capsule because inadvertently you can inject. So that is why we are substituting it with IPAC. So we do the IPAC and they do the injection of LIA and they avoid the posterior capsule completely. So they do the anterior and the medial and lateral. So it covers the entirety.
Hello. Neha, you're there?
Yes, 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 I'm very much.
Yeah, there's a question in the chat box for Murli.
Okay.
Hello.
Yeah, what's the question? Sorry.
Basically, did you get? I can ask Neha if you have missed it.
Yes, sir. Yes, sir.
Yeah. Suppose Murli, because maximum patients as a hip fracture patient, or elderly patient with some cardiac comorbidities, and they are
anticoagulation.
They are on blood thinners.
Yes.
So are you going to go ahead? There's a question from one of the delegates. Are you going to go ahead with the PENG block?
Okay. Now again, this is I would say a little bit of controversy, but we have given the reason being. Now, if you are going towards the bony landmark, as we mentioned, and you know where your vessels are, it is generally a route which is more like an intramuscular injection, and you're depositing it into the plane below the level of the psoas and above the level of the bone. So what we have found is if they are on clopidogrel or if they are on aspirin, which generally they are, we have gone ahead and given the PENG block because of the benefit that it offers compared to the risk. We are not near any central neuraxial structure, and there is nothing there which is highly vascular. So we have given the PENG block. I would definitely not give it in certain areas, but we have given it for patients.
Rupinder ma'am.
Yeah.
Same question to you. You have got the option, same patient coming, whether you will prefer a suprainguinal or a PENG block.
That was the question actually I had put to Dr. Murli. See, in our practice, what I have seen between suprainguinal and PENG, actually the results with PENG are not good at all. Patients are getting 6-hourly tramadol, and
did you add LFCN in that?
What is that?
Did you add?
Yes. I added LFCN in that. Yes, I added
this
that.
is for post-op analgesia.
Today morning only I gave a PENG and a LFCN, and I was I was telling my residents also. But with suprainguinal, yes, we had some good results. We are getting good results with it. At least for 6 hours post surgery, the results are good. But I have a point over here again. Basically, PENG block we are giving to patients we have a study actually going on. We have done around about 40 patients, and we are giving PENG block to patients who are going any kind of hemi or hip procedures under general anesthesia. And in suprainguinal, we are basically giving suprainguinal in patients in whom we are giving a subarachnoid block. So I really do not know, PENG is not working for us. At least it is not. Suprainguinal is working for us.
So I think what needs to be compared here is the PENG block with the good old simple femoral block. I think that will throw in a lot of answers whether this quest for our, we are chasing the obturator nerve, either in the PENG and in the suprainguinal, we are chasing the obturator nerve. Is it significant? There are studies comparing the suprainguinal with the femoral nerve block, and the differences are not much. So I think a comparison between the plain good old femoral given a bit higher up and the PENG are warranted right now. And that will throw a lot of light into this, because with the suprainguinal, we are adding so much more local anesthetic just to trap the obturator nerve, which is not 100% modality. We are
So
yeah, I think
yeah,
the best
I,
number
I, I
we
have
got
another
was
point here.
50%.
When you give a PENG block, it is basically a deeper block than what you are giving a femoral nerve block. So putting in needles so deep inside in a conscious and awake patient is, I feel, slightly
It's
difficult.
not very deep. It's not very deep. It's just below the ilius.
It is.
Quite accessible.
Dr. Ritesh, I think it's Arnab's question time at 9 o'clock. It's starting now. So I think you can take over as Arnab now.
Ritesh, can I just add on one thing?
Yeah, please.
Nation wants to know whether PENG block or Suprainguinal.
We have been practicing femoral nerve block along the long axis of the nerve. Means like we thread in the femoral catheter along the long axis of the nerve. I think Murli and we had a discussion, and we are it's an ongoing study like thing, and we do it in the preoperative phase, as block on arrival thing, and with this we continue it in the postoperative period also. We've been having an excellent result in positioning, and the patients who are on anticoagulation and all sick patients we are doing. I mean, even if the patient gets a GA, and then we'll continue it in the postoperative period. So with this, we have got a wonderful result, and we'll continue in the postoperative.
I think, yeah.
Final. When we have the results for the incidence of the operator nerve involvement in suprainguinal approach. This study we have completed. The incidence when we inject 20 ml of local anesthetic, 0.25% bupivacaine. Suprainguinal means we are not going through the traditional approach. We will scan the iliacus muscle as high as possible till we see the bowel. So it's not an Hubbard approach. It is much higher than the Hubbard approach. We will scan the iliacus muscle till we see the bowel and then drop. That is the highest point of the iliacus compartment. When we have injected 20 ml of local anesthetic, 0.255% bupivacaine, the incidence of operator nerve block is only about 25%. So we have stopped using suprainguinal approach. The incidence of operator nerve block, how we have tested is it is not having any consistent cutaneous innervation. We used a pressure bag between the adductor squeeze. So we look at the adductor muscle strength pre-op and as well as 30 minutes, 45 minutes after the block. So when we see that the incidence of the adductor muscle weakness is only 25%. So even in the highest iliacus compartment, 20 ml doesn't provide consistent operator nerve block. So trying to hit the operator nerve through the iliacus compartment is mere waste of exercise. So that we have dropped. So that's the evidence we have. We have yet to publish it. I mean, that's I wanted to put forth to the audience.
Shiva, I think that 25% adductor blockade that you're getting is by blockade of the femoral nerve and blockade of the pectineus muscle over there.
True.
Okay, with 20 ml, I don't think you're going anywhere. You're not going anywhere past the femoral nerve.
Very obvious. Because the pectineus influence itself will produce that influence.
Are we all trying to do the exit pathway of lumbar plexus being blocked at different levels with all this?
True, yeah, we are trying to do that through the anterior approach, but we are not. That's the point.
I think
we couldn't able to get the operator now consistently.
I think we should call it off a day. It's already 9.
Yeah. Thank you. I mean, it's such extensive.
Thank you to all the speakers. Dr. Salis, sorry, due to technological issues.
Yeah, I know. There's some problem.
We were not able to hear your wonderful talk. I think next time we'll make it happen. But thanks for being a part of this webinar and taking all the questions. Dr. TVS, Dr. Harshal, Dr. Surajit, Dr. Ram, Dr. Rupinder and Dr. Murli. It was a fantastic webinar. And thanks to both the moderators, Dr. Sumita and Dr. Neha, for taking it very nicely, the whole webinar. And thanks to all my excos for being a part of a great discussion. Thanks to all the delegates across the world who who have logged in our webinar. And next month, again on second Saturday, we will be there with the posterior approach of the lower limb, starting from top to bottom. And thanks Anaesthesia TV, thanks to Rahul, thanks to Fusifilm, and to all the delegates who you can go to the AORA website and you can download your certificates. It is there. This webinar certificate will be available after a week or so, but earlier webinar certificates are there in the website. You can put your email ID if you have registered for the webinar, and you can download it. Thank you, everyone. Good night. Take care. Bye-bye.
Good
Thank you,
night.
Dr. Tej. Thank you.
Bye-bye.
Good night. Good night.
Thank you.